1, 2. Test check 1, 2. Mic this. Check 1. Check 1. Test check. Test check 1. Test mic check 1, 2. Test check 1, 2. Check 1, 2. Check 1, 2. Test check 1, 2.
you have a slide changer? As you're all aware that thyroid function tests are one of the most used and abused tests in clinical practice. And most hospitals will run many thyroid function tests in a day, and many hundreds and thousands of thyroid function tests are done over many weeks. So there has been significant improvement in thyroid function in assay techniques over the last 30 years, which have made more precise understanding of our thyroid function. And most of the tests, what we do in daily practice, are simple and straightforward. Sometimes the thyroid function test gets affected by our drugs, clinical conditions, and rare genetic disorders as well. Rarely, lab interference due to your machines or interfering markers like neutrophil antibodies can also be a problem. With the advancement of thyroid function tests, we have newer genetic conditions which we have identified, such as thyroid hormone resistance, and more cases of thyroid hormone producing tumors have also been found. So when we say that how to assess thyroid function, we need to understand the physiology of hypothalamo-pituitary axis and the factors which govern thyroid hormone at both tissue and cellular level. We also need to understand how the laboratory measurements of T4, T3, and TSH interact with one another, and conditions that are associated commonly with anomalous TFTs or what we call as funny thyroid function tests. So when we say funny thyroid function test, we have two issues here. One is TFTs discordant with the clinical picture. For example, you expect hypothyroid, you suspect hypothyroidism and you measure, and then the patient has got hyperthyroidism. And then TFTs discordant with one another. So your TSH is suppressed where you would expect in a hyperthyroid patient to have high free hormone levels, whereas you will have still underactive lower levels of free hormone. So these are TFTs discordant with one another. So this is not a very common problem, but can happen. And sometimes your standard of the laboratory might also be a reason for it. So you're probably all aware that the hypothalamo-pituitary axis is the most important thing governing your thyroid function. And your TRH is secreted in the hypothalamus, which regulates your pituitary to produce TSH, which controls your thyroid hormone production. And there is negative feedback from assessing your thyroid hormone levels in the serum, which leads to signaling pathways back to your pituitary and your hypothalamus. This is tightly regulated through alpha and beta receptors, which are present in wide variety of organs, as you can see, in the brain, heart, liver, intestines, and your skeletal muscle as well. So predominantly, most of these have alpha-1 receptors, and the liver is respondent to your beta receptors. And TSH, the thyrotropin-releasing hormone, is produced from the paraventricular nucleus of the hypothalamus. And TSH has got two subunits. One is the alpha and the beta subunits. And the alpha subunit is commonly shared between HCG, LH, FSH, and the beta subunit confers more specificity to the hormone. And this becomes very important when you assess thyroid function tests in the context of pregnancy. So TSH secretion, as I said earlier, is regulated by negative feedback from the circulating thyroid hormone, and as well as it can be influenced by dopamine and somatostatin. TSH then stimulates the thyroid gland to produce T4 and T3. In general terms, the thyroid gland on its own produces a good amount of T4, like 100 micrograms of T4 every day, and directly secretes about 6 micrograms of T3 into the system. But most of the T3 which is formed is from peripheral conversion of T4 to T3. So this is the understanding as we would see. The potency of both these hormones are very different from one another. The T4 is very protein bound, whereas the T3 is mostly free and hence more active. So this is why we have been told always your T3 is more active because of the potency and the protein binding of the hormone. The half-life as such, T3 has got a half-life of less than 24 hours. half-life of T4 is 5 to 7 days. And the TSH is the most tightly controlled hormone in the whole system, and it's got a very log linear relationship with T4 and T3 as such. I'll give you a slide in my next slide to show what is a log linear relationship means. The current assays belong to the third generation, which are very, very specific and gives us a functional sensitivity to around 0.01. So if you really see a 0.01 and a less than 0.01, that signifies that there is greater suppression of TSH, and that sometimes helps in diagnosis as well. We'll go on to that in the later cases. The current debate about whether to reduce the TSH reference range is going on as ever for the last 2 or 3 decades. But newer evidence has suggested that some populations like the Indians tend to run a higher TSH compared to Western populations. So you need to be aware, and this is changing our current practice, especially again in pregnancy. So the free hormones are the ones which activate our nuclear receptors. The reference standard for analysis is equilibrium dialysis, but this is not widely available. Most commonly, a sensitive immunoassay is currently being used. What is called the advancement is called CLIA, and I've given you the adult reference ranges. When you measure T3 and T4 at lower levels, like patients with hypothyroidism, FT4 is much more reliable than a free T3, and free T3 is more reliable in patients with hyperthyroidism. And this is what I call as a log linear relationship. So a 2-fold change in your free T4 will lead to a 100-fold change in your TSH. So just by bringing down your T4, free T4 levels from 1.8 to 0.9 will raise your TSH by 100-fold. So this is where TSH becomes the most important test, and the assays of TSH are also very sensitive because of the technology involved in that. It's a double sandwich technology, which most TSH assays use, which are very accurate in terms of reproducibility. What is normal TSH? We are all aware that different reference ranges exist, but we all run a TSH which is within a mean. So generally, if you measure particular individuals over a 12-month period, as the study was done, you run a mean TSH around a marker where there is a set point, and it will change to an extent, but it will remain. There is generally a mild variation between your TSH and T4, but you stick to your mean most of the time. And the median TSH is around like about 1.5 in the whole population in this particular study, which has been widely quoted. And when you talk about TSH, a thyroid function test, TSH is the most excellent test. You can do one test, then it's going to be the TSH, except in certain conditions. So when you're suspecting pituitary disease, we don't go by the TSH. So that's one thing. Certain drugs can alter your TSH. For example, glucocorticoids, high-strength glucocorticoids can reduce your TSH. Your dopaminergic drugs can reduce your TSH, and metformin can have some chronic action on your TSH. So, and TSH has also got some diurnal variation, which can cause minimum variation to your numbers. Rarely, abnormal isoforms have been identified, and heterophilic antibodies, when you have some patients carry this, can affect your TSH as well. In patients like early phases of pregnancy, your TSH also, you need to measure it with other hormones to make a good example. And adrenal insufficiency, rarely untreated adrenal insufficiency can raise your TSH marginally, which can also influence your TSH. So you need to be aware before treating a mildly borderline test to make sure that your adrenal glands are working at least by a few clinical questions. Other factors which influence your TSH is your age, gender, BMI, iodine intake, ethnicity, as I said earlier, can affect your TSH. And compared to the African Americans, which I've quoted the numbers here, the Mexican Americans tend to run a higher TSH, and also white Caucasians tend to run a higher TSH. I've given you some values for different populations where they've had particular TSH cutoffs, so which you can note. Recent data, this is primarily we have looked at from the pregnancy point of view, but there are data suggesting, I just want you to concentrate on the Indian levels here. Our trimester specific reference ranges are much, much higher than the Chinese and when compared to the Westerners. So this is kind of new data which make us rethink our management of pregnancy. So if you look at the numbers here, so the Indian reference ranges done by Dr. Marwa et al. Has got the highest levels of TSH in all through the 3 trimesters compared to Chinese and the Western populations. So you've got to be, we're currently, this data is fairly new in the last few years and the guidelines are still evolving. So we've gone through this already. And when we talk about thyroid function tests, there are particular patterns which evolve, and this is a graph which is widely published and present in many papers by Professor Gurnall, and these are multiple thyroid function tests which is available for you to look and read. For the starters, I'm just going to give you some basics to evolve and start. This is how we diagnose hypothyroidism. A 24-year-old lady, this is straightforward hypothyroidism. And a patient comes to you with heavy periods, constipation, tiredness, fatigue, and mild weight gain for 3 months. These are classical symptoms. Her GP suspects hypothyroidism. And in general evaluation, her TSH is greater than 150 and a free T4 of 0.8. So this is straightforward hypothyroidism. How to interpret this? This patient has got clinical symptoms. Our pretest suspicion as a physician is very high here for hypothyroidism. We have checked the thyroid hormone levels as such in free T4, which is low. And the feedback, the pituitary gland is obviously working and the feedback is very well maintained, so that causing elevation of TSH. So our diagnosis here is primary hypothyroidism, where the thyroid is not functioning, whereas the pituitary is trying to maintain normalcy. How do we assess severity and what happens in the natural history of the disease? Normally, the TSH starts going first over the few months or the first couple of years, followed by a rapid decline in T3, and then the TSH markedly rises. So this is kind of how the natural progression of the disease. And if you've got an antibody positive such as ATPO, the progression is more significant and more rapid. And moving on to our next basic case is a 40-year-old lady, mother of 2 children, recent weight loss of 5 kgs in 2 months, complains of anxiety and palpitations. She has got neck swelling and stare, and on evaluation gives you the following thyroid function tests. Her free T3 is well elevated at 11.5. Free T4 is also elevated at 4.8 and a TSH of less than 0.01. And here our pretest clinical suspicion for hyperthyroidism is high. Hormone levels are also high. There is appropriate feedback. Since the hormone levels in the blood are high, the TSH is well suppressed, and we diagnose thyrotoxicosis. So this is basic stuff. And our differential diagnosis normally for hyperthyroidism is, it could be Graves' disease, it could be thyroiditis, or if somebody is already on treatment, they might be over-replaced. These are our standard cases. Moving on to other cases. This is our case 1, 24-year-old lady, known hypothyroid on 200 micrograms of thyroxine, heavy periods, constipation, tiredness, fatigue, and mild weight gain for 3 months. She visits a general physician, and following which she does these tests. And a TSH again shows us greater than 150 and a free T4 of 1.48. This is supposed to be a workshop, so members can interrupt me anytime if you want, or ask me any questions. So we can keep this interactive if Dr. Murthy permits as well.
Please.
Yes.
Please.
Yeah. So any questions you can ask me or interrupt me with the raise of hand, please. So this lady, the explanation here is she's got a very normal free T4 and a very high TSH. So here the hormone levels are high, and the TSH, when the hormone levels are high, we expect the TSH to be suppressed. And the history is the key here. A very high normal TSH and a normal T4 suggests that the patient has been non-compliant to her therapy and taking the medicines just a couple of days prior to her visit. So this is the most commonest problem which we see in clinical practice. I think Dr. Bharat will go on to that as well in his cases. So non-compliance to levothyroxine medicine is the most commonest picture for the thing I've shown you. So the patient thinks she has not taken it for a couple of months. She wants to visit the doctor. Her thinking is to take the medicines for 5 days and visit the doctor. But the TSH will not come down just like that. So that's the most important thing. Rarely interference with absorption due to various reasons. The patient is not following an empty stomach pattern with the thyroxine as advised. Rarely generic thyroxine these days are widely available and are also a problem in today's world. So how to ensure compliance, that medicine has to be taken every day on an empty stomach, daily for 2 to 3 months at least for the TSH to remain suppressed and to reach an equilibrium. Rarely in Western countries, thyroxine can be given also at bedtime, but you need to at least maintain a 3 to 4 hours of empty stomach prior to your thyroxine. So an early dinner before 6 o'clock and your thyroxine at 9 to 10 o'clock might be possible, but in an Indian setting, I would doubt how it can be effective. So I've explained to you how this happens. So this is most commonly a compliance issue due to the patient. Moving on to our second case, 62-year-old lady, headache on and off and increased tiredness. She looks pale but normal, said to have had normal thyroid function test, but her old reports were not available. And this is a common problem. Patient walks into a clinic with just one report. And her free T4 is 0.62, well down at 0.62, and her TSH is normal. So this is, we would expect if she looks pale, headache, on and off, increased tiredness, we would expect the TSH to be high, but it's not happening here. So our interpretation is pretest clinical suspicion is high, but our thyroid levels are low. The feedback here is inappropriate. So that's the concern here. So you reevaluate, you do a double check of your thyroid function test another day. And if it is the same, then you're talking about central hypothyroidism here. Further evaluation of other anterior pituitary hormones here with this patient went on to find hypocortisolism and hypogonadism, which means the patient is suffering from hypopituitarism due to a large non-functioning pituitary adenoma. So this is a central hypothyroidism, what we are looking at in a patient with hypopituitarism. So that's where the subtle symptoms, the results are also very subtle here. So you need to be alert when somebody tells you that they have got normal thyroid function tests in the past. Our case scenario 3 is 30-year-old lady, married for 2 years, confirmed pregnant at 8 weeks. As a part of other evaluation, a thyroid function was done and her total hormones are elevated with a TSH of 0.9. So in pregnancy, we are all aware that the total hormones will be elevated. So this was a routine check. Her thyroid hormone levels are high. Feedback is not suppressed. So you can, if your lab is very good, you can convince the patient that this is pregnancy-induced thing. Go through a good clinical history with the patient, make sure that they do not have any symptoms suggestive of hyperthyroidism. And if it is, you can close the chapter. If you're in doubt, you can also estimate your free hormones at that time, which will also convince the patient also. So her free T3 was normal. Free T4 also was normal, but before doing a free hormone check, especially in pregnancy, you need a good lab backup. So a decent lab is a primary requirement. So we checked her levels 4 weeks later, and the TSH went down further with this almost similar upper end of normal. And this is primarily related to the HCG-like activity affecting your TSH. So this is very important to know that first trimester, your HCG peaks around 8 to 12 weeks of pregnancy. And this could be related to pregnancy-induced changes, where you can see on the screen, the HCG has got thyrotropic TSH-like activity, which pushes the hormones to the upper limit of normal, which causes a raised elevation of free T4 and TSH to the upper limit of normal. Certainly, it won't be two or three-fold as you would see in hyperthyroidism. So this is a very common problem which we face early on in pregnancy. So being aware of the condition is very important. If at all there is a doubt, we can also have TSH receptor antibodies done to confirm the diagnosis. So this is what happens if you look at here. Sorry. So if you look at here, your median level of TSH drops around the 12-week mark, and then it normalizes after 14 to 16 weeks. So early on in the pregnancy, there is some suppression of TSH, which is very common. Our fourth case is a 62-year-old male, had an episode of atrial fibrillation, started on amiodarone and warfarin for 11 months. He complains of fatigue, muscle weakness, increasing dyspnea, edema, weight gain for 2 months. And his pulse was 110 beats per minute, irregularly irregular. He appears malnourished and has got evidence of heart failure. His free T4 was 12.2 and free T3 is also elevated at 10 and a suppressed TSH. And echo shows LVH with normal systolic function. Thyroid uptake scan shows his gland is visible with some uptake, and he was treated as heart failure, and the cardiologist discontinued the amiodarone and put him on bisoprolol. And what should we do next? Amiodarone is a common drug which is used in cardiac practice and has got multiple physiological effects on the thyroid gland, and it both causes dysfunction as well as hyperactivity. Due to time, I'll skip these slides, but increased TSH is very, very common in the first 3 months of initiation of amiodarone, so you got to be careful. We do not treat minimal elevations of TSH with results of minimal elevation doesn't need any treatment. Stopping the amiodarone doesn't actually help immediately with these conditions, so stop if possible, if not, leave it alone. LT4 levels to keep the TSH levels around the upper limit of normal. So anywhere around 4 or 5 mark is good enough for these conditions, and do not try to suppress the TSH in amiodarone induced hypothyroidism, because then you will run the risk of hypothyroid state. So it also causes 2 pictures like autoimmune thyroid Graves' disease, hyperthyroidism, as well as a destructive thyroiditis. So it can cause hypothyroidism, it can cause a thyroiditis-like picture, and it can cause hypothyroid state. And most of these are identified by doing an technetium scan, which can help. It can also help by doing some inflammatory markers. If it is a type 1 event, then basically you need to stop the amiodarone and you need to start them on carbimazole. If it's a thyroiditis-like event and you suspect amiodarone to be the culprit, then corticosteroids may be helpful. So skip this. Our case scenario 5 is 20-year-old male, presents with palpitations, diffuse goiter for 5 years. So he's had a long-standing goiter. He's below average in study, shorter than his younger siblings, and his biochemical evaluation shows a free T4 of 4.8, free T3 of 7.7. But the surprising bit is he has also got an elevated TSH here. So our pre-test clinical suspicion because of the goiter is this guy has got hypothyroidism, but his hormone levels are elevated. His feedback is also not appropriate. So his TSH is not suppressed as we would expect. This is a condition with mental retardation, mild mental retardation, short stature, could be generalized thyroid hormone resistance. And in our country, the easiest way is to check his family members. And if they've got a similar picture, you understand that this is thyroid hormone resistance. And currently, we are on the process that we should be able to genetically evaluate these individuals in the near future. So more and more genetic studies are available in our country. So this is a heterogeneous syndrome, reduced response to your thyroid at various organs in different probabilities, and increased TSH tries to maintain the thyroid hormone levels in the necessary thing, and it can be probably generalized, or just the pituitary can be unresponsive to your TSH. The differential diagnosis for thyroid hormone resistance is TSH secreting pituitary adenoma. So that's the differential diagnosis. And my 6th case is a 35-year-old male who was admitted with a febrile illness for 10 days. Pneumonia, clinical condition is worsening, and he's on ventilatory support over the next few days, and he's got multi-organ dysfunction. And his thyroid function tests were checked because he's got tachycardia, unexplained tachycardia. So his thyroid function tests were checked, which shows a very low free T3, a very low free T4, and his TSH is also on the lower side. So this mimics central hypothyroidism. So his hormone levels are low, his TSH is also low. It mimics pituitary dysfunction. But we need to, when you're interpreting thyroid function tests, you need to see the clinical context here. We've got a sick guy in ICU. So this is basically the patient is very severely ill. So you cannot interpret this thyroid function test because this guy has got sick euthyroid syndrome. When the patient becomes very unwell, the body has got protective mechanisms to execute. So it goes into a low BMR rate using these mechanisms. So a sick euthyroid syndrome is the most likely possibility here. And you just have to clinically assess the patient, examine them, and then maybe a diagnosis can be confirmed retrospectively when the patient becomes well. So the reasons for this is TSH still offers the best test here. You can do free hormones, but there is also impact conversion of free T4 to T3. There are various changes which happen during these phases of illness. So it depends on how many weeks and how much the illness is, where you do TSH initially drops and then starts going up, and it gets elevated after 4 to 6 weeks before it normalizes over a couple of months. So this is what the TSH does. And then you've got this T4 which drops and normalizes as well. So do not check thyroid function tests in a critically unwell patient unless or until it is necessary. Even in any sick patient, if you suspect thyroid function tests, suspect thyroid dysfunction, wait for some time if it is possible. This is a newborn male baby whose thyroid function test was done as a routine screening on day 2 of life. A free T4 measurements was on the upper limit of normal and a TSH showed it's 22. The parents were very much concerned about the baby's thyroid status. And normally we do screening in most babies and we advocate universal screening on all pregnancies, definitely not on just hypothyroid mothers. Universal screening is done in most Western countries these days, and we will be moving to universal screening as well in the near future. But the time of testing is very, very critical. So we need to just kind of make sure that the baby, you measure the TSH and free T4 on the 3rd day at least. You need to wait for 3 days. 3 to 5 days is the best time to do your thyroid function test for the baby. If you're doing it anytime prior to 72 hours, and this is a picture, you will get an artificial elevation of TSH, which will make a repeat screening necessary. And you also need to be aware free T4 cutoffs are different for infants. TSH is higher at birth and takes at least 48 to 72 hours to settle. And this baby was tested too early, and hence the suspicion of hypothyroidism. Have we got time, sir?
Right. I think plenty of time.
Yes, sir, that's recommended, certainly. In private practice, most nursing homes and hospitals have started doing it. The timing is very, very important.
Pregnancy first trimester, you said, sorry, I couldn't ask at the time.
Please tell me.
Pregnancy, you said, in first trimester, there is a suppression of TSH. What is the reason, sir?
The first trimester thing is due to your HCG. Your HCG starts going up around the 8-week mark and peaks around the 12-week mark. And as I said, HCG as a hormone as well as TSH as a hormone has got 2 alpha and beta subunits. The alpha subunit is very, very common to both of these hormones. So when you have a very, very high peaking of HCG, the HCG cross reacts with your TSH receptor and the TSH receptor is stimulated. So the HCG has some thyrotropic TSH-like activity, which causes the hormones, like especially your free hormones, to go up around the 12-week mark. So once the HCG starts dropping down after that, it will automatically normalize. The confusion happens normally whether the patient gets worried or the gynecologist gets worried whether it's hypothyroid state. But generally around the first trimester between 8 to 12 weeks, this is a common issue. Rarely in 10% of patients where there could be a further drop of TSH which causes a problem, and then the confusion happens.
Specific to parathyroid, the primary, secondary, tertiary, quaternary, like that we decided. Similar look, we had to do it through thyroid also.
Yes, you,
Primary, secondary.
you can, when your thyroid gland is dysfunctional, you call it primary hypothyroidism. When your pituitary gland is dysfunctional, we call it secondary hypothyroidism or central hypothyroidism. When your hypothalamus is dysfunctional, you can call it as tertiary. But because of the most accurate things of TSH, we don't need to really measure TRH unless or until you have a tumor or something like that. So the need for that is not there anymore because of our highly specific TSH values. So these days, we don't even do a TRH stimulation test at all, unless or until rare circumstances need to be done.
Just for the sake of some interaction, you talked about discordant values and heterophilic antibodies. Could you just elaborate on that?
I think I've got one more case. We can finish it off
Okay.
and then.
Yeah, no.
So this is our next case. It's a 45-year-old male. I'll quickly pass through this. Recently moved banker from Mumbai, who's a Blue Cross member. Routine visit to his endocrinologist. Normally euthyroid on 150 micrograms of thyroxine, and his free T4 values are normal with a high TSH values of 96. And he's adamant that he's taking his thyroxine very well. So he doesn't have any clinical symptoms. His pretest suspicion is nil. Thyroid hormone levels are normal, but unfortunately his feedback shows that his TSH is well elevated. And this patient is adamant he's taking it and he's taking it correctly. So we do a couple of tests, both of them show the same thing. And this is where we talk about antibody interference as a problem. Due to time, I'll just go through this. We use multiple assays. The current assays which we use is a CLIA, which is a chemiluminescent immunoassay. The older assay where we started is a radioimmunoassay. And this is what I call as a, this is a common TSH based principle, non-competitive immunoassay principle, where you use two antibodies, which is one is with ruthenium and one is a biotin based antibody. And your antigen here is the TSH. And when these two combine and form a sandwich complex, and that's where it lights up and we measure it. So here, what you see on the left panel here is your capture antibody and the label antibody, and you assess the true analyte, which is a true positive. So this is where, when you normally do a correct TSH, when you have a heterophilic antibody, which can be due to many reasons in some people, what does is the heterophilic antibodies link up as a false analyte and gives a signal as well. So without an analyte, you get a positive signal on this test, and this is due to a false positive heterophil antibody. And this is, there are multiple things. Commonest patients who get heterophilic antibodies are people who rear animals, birds, and so on. Rheumatoid arthritis can also happen it, make it possible. So this is kind of a heterophil antibody, which is due to that. So I think I'll stop here and I'll give Bharat the chance to speak.
Yeah. I'm
Yes,
sure
ma'am.
there should be more.
I can't hear you. Take it.
Who is on thyroxine, so case of hypothyroidism, getting married, pregnant, and due to the impact of HCG level, the TSH will increase again, or it will, because she's already in thyroxine. So
See, assuming that she's on 100 micrograms of thyroxine and her TSH is 2.2, we would expect a small dip in her TSH during the 8 to 12 weeks mark. We expect that, and as long as it is remaining stable, we would not alter her thyroxine. But most women, when they become pregnant, that they will need a 25 to 50% increase in thyroxine between the first and the second trimester. Up to the 24-week mark, their increase can happen. Most of this will happen around before the 20 weeks. So generally, if somebody is on thyroxine and they become pregnant, if there is a possibility, you check the TSH and alter it 25%. If you do not have facilities or the patient is traveling somewhere, you ask them to put it up automatically by 25% and do a check in 4 weeks time when they return. So
We have to increase the dose.
certainly in most pregnant women, they will need an increase in dosage.
And after 20 weeks of pregnancy,
It will be more stable. So we
again
ask the,
reduce.
no, we don't decrease it. We keep it going until the end of pregnancy. When the baby is delivered, you ask the patient to revert back to her pre-pregnancy dosage. So this is due to the increasing needs. Normally, your own thyroid will bump up your needs during pregnancy. When you're replacing it from the outside and the thyroid is dysfunctional, you have to do the increase. That's all. Or we have to, as physicians, we have to do the increase.
So one more doubt, sir.
Please tell me.
It's basic, but I just want to know the dosage of the thyroxine in hypothyroid. Starting with
So,
dosage of thyroxine.
right. Like, for example, for our first case, we have got 150 of TSH. This is a young lady, so you don't need to really worry. You can just, if the lady is around 60 years old, 60 kgs, then we'll start her just straight away on 100 micrograms of thyroxine and do a recheck of the thyroid function in 2 months. That's more than fine. This is normal. The patient is not pregnant. Straight, you put the patient on a higher dose of thyroxine as long as she is healthy. The same thing might not be true for a 76-year-old who's walking into your clinic frail. If the same values of greater than 150, I met a chap yesterday, 74-year-old frail, has a TSH of 150, and I started him at 50, tell him to come back to me in 10 days, review him for how he is medically, and then we bump it up gradually. So what happens is if you're increasing your metabolic rate suddenly in an old, frail, probably an unknown ischemic heart disease patient, then you might be precipitating heart failure or even an anginal episode. So you've got to be careful. In a younger patient, no worries, less than 50, no clinical symptoms, nothing, you put them straight on 100 and then review it. The idea is you will need around 1.6 to 2 micrograms of thyroxine for each patient. Most of this is dependent on your lean body mass. So that doesn't change much in most people after a while. So this 1.6 to 2 is very, very easily applicable for most patients. So that's where this 60 kgs and 100 micrograms comes from. And the final subtle titrations you can do afterwards.
For menopause women, sir, because mostly women were not hypothyroidism, and after menopause, after 6 months or 1 month, they develop this hypothyroidism. So dosage to start with.
Dosage to start off with, again, if the patient is 150 and the patient doesn't have any heart conditions, yes, bump it up straight. If they've got subclinical disease, matters are different. So if somebody has got just a TSH of 10 and the free hormone levels are very, very subtly low, then I'd probably start her on a 50 or a 25 and gradually work it up. We have got time on our hands, so just start them on 25 micrograms of thyroxine or 50 micrograms of thyroxine, whichever you're comfortable with, and you'll be always
Whatever the TSH level.
10. For example, if the TSH level is 10, I'd probably start on a 50 and then go up.
Normally they don't show 10, they show 6, 7 like that. No.
6, 7 is you don't really need to start immediately on these patients.
But they
at all.
have clinical symptoms.
I would, in that case, look for other problems in the patient because subclinical disease rarely causes symptoms. You need to exclude other causes for their symptoms before. Most of the guidelines will tell you that you need at least 2 TSHs apart, 6 weeks apart, greater than 10 to start treatment. Unless or until the patient is a pregnant woman, mental health illness, or other issues with the patient which are needing urgent care. So 10 is a global standard for starting thyroxine therapy.
Now, frankly speaking, it is me.
Okay.
So menopause started, and after 6 months of menopause, I got like sweating and some symptoms and all. So I checked the TSH level. It was around just 6 or 6.5, I think. So 7, between 6 to 7. And so everybody told me, like in our group, doctors group, they said start with 75. So I started 75. Then I checked again after 3 months and it was normal and I reduced to 50. Like
Well,
that. So I don't know, I'm still on 50 microgram.
I
of,
think I would have rather waited for some more time before you would have started treatment. I would have checked an antibody status as well. And generally, the hormonal changes happen during menopause. You will have subtle changes.
So no
Wait.
need to take.
Now we have started, the thing is different, but for people, for other people's values, I think we would wait for TSH2 readings at least 6 weeks apart, greater than 10, before we start treatment. That's the guidelines, unless or until they've got specific other issues which mandate early initiation of therapy, which is most commonly we do in mental illness or somebody with severe GERD or um, pregnant women. So those are the pressing problems where we start things early.
Okay, what about me? I am both physically and mentally very strong. And
I
I
wouldn't
don't
have
have
started
any other symptoms and still I am on drugs in 50. So what should I do?
I wouldn't
Do I-
categorize you as a patient.
So what
Uh,
should I do? Can I stop or
You can certainly stop and see now.
how to stop? Should I reduce the dosage to 25 and then to stop?
Yeah, that would be a good
Or-
step because we will know that if you're requiring those agents now. So reduce it to 25. If
For
you
how
sudden-
many months?
For a couple of months and then do a retest. If your TSH is jumping, then you know that you're needing it. And then you can keep it on. If it is still the same TSH showing up after 25, then you can stop for a couple of months and then, but the important thing is being on follow-up. So monitor it 3 to 6 monthly and follow it up, and then we can see whether you're truly needing it.
Okay, how many tests I have to do in
3 monthly testing is,
Three. first 3 months I do one test and again.
I would
after
probably do it twice in 6 months and then go
Okay.
to 6 monthly follow-ups.
And if I don't, if the TSH level doesn't go up, then I
Yeah,
can.
always it's better to warn the patient about any constipation or difficulty in waking up. Those are the common symptoms which patients present to you with hypothyroidism. So tell them to watch for these symptoms. Weight gain is a very, very non-specific thing. So these are a couple of things, or any acidity or gastric issues, tell them to come back and do an early test. So if you tell them even a 1 year follow-up, you can always tell, watch out for these symptoms. If you do develop these, come back to me and we'll do an early test. So that's why we can keep the patient on the watch out.
And my weight never reduced because I always do some diet. I follow the
I
diet.
think the Krishna will probably have to pay more for this because weight is a big kind of talk about weight and hypothyroidism doesn't coexist at all. All the data shows that there is no relationship with weight gain and hypothyroidism. So basically, there is no data to suggest that hypothyroidism causes weight gain. And this has been taught out. There has been fights with women right groups in the UK and the US for endocrinologists saying this, but there is no relationship whatsoever saying that hypothyroid patients tend to carry on their weight or get worse on their weight because of hypothyroidism. So this is a popular myth propagated for a long term by many sources all over the world, and it's still propagated on the internet. But I think the real science behind it is very, very lacking.
But whenever the girl or women come to our clinic to, and complaining about the weight, we ask them to do the thyroid test one. That is the first.
That is just that will satisfy our patients, but I'm not sure whether it is a real
No,
science backing for it.
I'll just elaborate and add on to what Dr. Muthukumaran has been discussing. First and foremost, you treat the patient or the individual, you don't treat numbers. Actually, what you said is very, very true. Very many times you see borderline 5, 5.6, 6, 6.7. And like Dr. Muthukumaran said, wait for it to go to 10. And this mild form of hypothyroidism, or what we call as subclinical hypothyroidism, is not a medical emergency. So you could, repeat it after a few months or a few weeks, and if it goes up, then fine. Next, the symptoms of hypothyroidism are all mainly non-specific. Many other lethargy, dullness, constipation, and a whole lot of them non-specific. So unless you have definite symptoms, you may have signs and symptoms like a goiter or positive thyroid antibodies, or keep it in a pregnant state, like Dr. Murthy, then only you have to be a little more aggressive about starting therapy. So you could wait. Coming to the myth of weight, yes, at one time, thyroxine was also prescribed for weight loss. That's very true. And then it was realized when we talk about weight, we are concerned about fat. Till date, we do not have any drug which can melt a person's fat. And with excess thyroxine, you're only going to break down lean body mass, the muscles and bone. So if at all an individual on excess thyroxine is going to lose weight, it's not a healthy weight loss. It's only at the expense of breaking down the muscle and bone, which is not healthy. So any symptom signs, including weight gain because of hypothyroidism, like Dr. Muthukumaran said, it's probably of a very mild or moderate. Once you are on thyroxine therapy, what happens is you normalize. Any residual weight gain which stays is not because of hypothyroidism. It's like blaming Pakistan for all our woes. Of course, because of Pakistan, we do have problems. But for every problem, we can't be blaming thyroid. So many times, we unnecessarily blame the hypothyroid state. So once you corrected hypothyroidism, all signs, including weight, are all going to revert back to normal. And definitely keeping weight in mind, you should never put a patient on thyroxine or start. And especially as you said, in a postmenopausal state, weight loss may be at the expense of breakdown of muscle and bone, which is lean body mass, which is not healthy. So again, summing up the whole thing, 5, 6, 4, 7, all this don't bother. If at all, probably in pregnancy, that's a sensitive thing. Otherwise, wait, repeat it after a few months or a few weeks, see whether it goes up and start. Because hypothyroidism is not a medical emergency, nothing is going to happen. And another frequently asked question is for the audience sake. I'm going to ask you, is it always necessary to do a testing on a fasting state?
Not necessarily, sir. It depends on your practice, basically. We generally tend not to do, we do random testing. If at all, there are some data to suggest that there could be minimal variations of your TSH, but in clinical practice, really that doesn't matter. So in my clinical practice, we do most of it as random testing. If at all the patient has taken the tablet, we tell them to wait for a couple of hours after the tablet so that your free T4 values don't get altered too much. The TSH doesn't change much at all as long as the patient is taking the medications currently. So we follow through with random testing in most patients, and that's more than clinically sufficient for our day-to-day practice.
In pregnancy, which would you prefer, total T4 or free T4?
Fortunately, being in Chennai, we are fantastically backed up by most of the advanced systems. So we have an access to sitting on a backyard, which gives us the most precise technology, what I showed you within, and it's very, very highly reproducible. So we favor the free hormones because we have got that on board. In a rural setting, it might be challenging. People use these ELISA analyzers, which are very, very fragile. And it's like you making tea out of a coffee machine, which is precise, and your wife making coffee machine, which the choice is yours, obviously. But sometimes the automated analyzers have helped a lot in more precise measurements of thyroid function. And in Chennai, most big labs would use all these analyzers I'm talking about, and it's fairly standardized if you're going with the big players. The small players, we really have to check.
Sometimes in pregnancy, you have an isolated low free T4 with normal TSH.
That's a very good question, sir. The free T4, if you watch all the pregnancy data, and if you've got previous values, literally there is nothing to worry. As long as the TSH is maintaining on the same dose, if you've got a slightly lower T4 on the lower limit of normal, we generally not worry about these things at all, because most automated analyzers I'm talking about, and the values also shows that the free T4 levels will be on the lower side starting after the 24 weeks of pregnancy. So this is a isolated low free T4, which has been widely reported all over the world for many decades now. So that's as long as you're aware of this and your TSH is stable and you're able to maintain your TSH to less than 3.5 on the second and the third trimesters of pregnancy, I'm okay with it. The challenge becomes when somebody comes with one thyroid function test on the 34 weeks of pregnancy. Again, knowing this, and if it has been done in a central lab, a good lab, and there are no symptoms to suggest central hypothyroidism, I would sit tight on it, wait for the patient to deliver the baby, and take it on from there.
Very true. And sometimes iodine deficiency can be associated with low free T4.
That's right, sir. The thing is, we always tell our pregnant women to make sure that they take iodized salt, because the new fancy of all kinds of Himalayan salts are in the picture these days. So generally, when there is a goiter, we tend to check with all our patients that whether they are taking a good iodine diet. So it's more so important in your pregnant women. So that's where, in today's world, yes, you have to check that with your history as well, because that's the more better marker than doing tests for that.
And another issue which you raised and explained very well, either a hypothyroid mother delivers or newborn screening, a value comes, they get confused. So, which day would you think would be the ideal time to check even the first time?
The first time for the baby would be the third to the fifth day of post-delivery is the most ideal time, because your HPA axis would be mature enough to check it. So that's one thing. For mothers, a recheck could be done anywhere around the 6 to 8 week mark. So that's the advice, because again, as you have mentioned, the central sick euthyroid syndrome, if the patient is delivered immediately and you do a thyroid function test on the next day, it's going to be altered. So we just tell them, if they're taking thyroxine, to go back to their pre-pregnancy dose and do a test around the 6 to 8 week mark. So that would be a better choice for most of us.
Any questions on the virtual platform? Anyone who's monitoring that? Are there questions on the virtual platform? Because the next talk is going to be on management of hypothyroidism. That's why we're trying to finish this before we go. Right? Any questions? Sorry, not able to sit in to see two bright lights.
So I see most of your prescriptions are here, and I mean, come across through all the specialists' opinion sometimes. Some people mandate the use of folate and while using entroxin, and some of the prescriptions do not mention folate at all. What do you think in your personal opinion?
Folic acid, sir.
Yeah.
Folic acid is mandatory for pre-pregnancy counseling, and any woman trying to get pregnant needs to be on folic acid. That's the thing, my understanding of it. It doesn't need to be, most of the time we tend to give folic acid when the woman gets pregnant, which the research evidence behind that is questionable. So pre-pregnancy is most important in our women. Mandatory with hypothyroidism, I'm not sure. So
while taking thyroxine, while you're giving eltroxin, most of the prescriptions indicate that folic acid is there.
I'm not aware of any data needing folic acid as such, but my understanding is that B12 prevalence is B12 deficiency is highly prevalent in our country. So that's one understanding, but I'm not aware of any signs needing folic acid supplementation with thyroxine.
Okay, thank you.
Any questions on the virtual platform?
Excuse me,
Yes, sir.
when the child is not doing well in the school, they put the brunt on the doctors and who are managing before. Is there anything
Even for obesity these days, that's the problem. You talk to my child, I can't talk to them. So that's the problem. I tell them, if he doesn't listen to you, why would he listen to me? So, but I think if anybody is not, on a serious note, if anybody is not performing well at school, yes, a mandatory thyroid function test can be helpful, especially in children with disabilities. It's very important. Children with chromosomal abnormalities, it's very important. CP children, premature children, they're all at a higher risk of thyroid dysfunction. So if a parent comes to you, genuinely, we do a blood count to exclude other abnormalities. Also do a sugar check and a thyroid test. It's not going to cost you a fortune. And these are simple tests you can do to reassure the parents as well as to take it to the next level.
Excuse me, sir.
Yes,
6 weeks pregnancy with the TSH level is 215. Shall I ask her to continue the pregnancy, or I advise to terminate the pregnancy?
I think we know that hypothyroidism untreated can cause changes to the unborn fetus, but there is no recommendation as such to abort the fetus. So what we tell the mother is to tell them to initiate thyroxine as soon as possible at the highest dose. So in your mother, I would probably go up to, depending on the weight, I'd probably start at 100 or 125 or even
Already
one.
started thyroxine 200 microgram, because I discussed with Dr. Smriti Chandrasekhar and then started with 200 microgram. Because her
The
weight
recommendation is
92 kg. 92 kg.
92. So I would have probably started for 92 kg at 150. Ask them to ensure empty stomach on the thing, give them a good gap so that we reach the level as quick as possible. The earliest check you can do is at 3 to 4 weeks time to make sure that the thyroxine is going in. The recommendation is not to abort these fetus, but increase the monitoring of the growth, and you might want to do an extra first trimester scan, growth scans, extra growth scans, and make sure you get an anomaly scan, detailed anomaly scan as well. But the recommendation is not to abort with these pregnancies.
Thank you.
Excuse me, sir, I have a doubt.
Yes.
So for postpartum, so I have to go back to the previous, before pregnancy, how much thyroxine they were on? Immediately on day 1,
Yes,
and then after recheck after 6 weeks.
that's right. Yeah, that will absolutely work perfectly
So
for most
if-
mothers.
suppose in pregnancy, if they are taking 150 micrograms, and if it was only 100 micrograms pre-pregnancy, they can directly go switch on to 100
Yes.
micrograms.
Immediately the day after delivery, the next morning, the mother can go back to her pre-pregnancy.
Pre-pregnancy and then after recheck.
That's right.
Thank you.
In our clinical practice, Dr. Murthy has got more than 3 times experience with me. But in our clinical practice, what happens is, if you take the drug correctly, there are very, very handful of patients who need more than 175. Maybe an odd thyroid patient who has had a surgery may need a 200. The days of 300 and 400 of thyroxine are gone. If you use a good standard thyroxine available in the market, any of the good branded ones, then you shouldn't be needing anything more than 200 at all. The rarest of the rare patients in pregnancy can go up to 225 or something, but those are only a handful, 1 to 2% of individuals. We are talking about 98, 99% of individuals are needing mostly below 175, 200. So we don't have those days and age of prescribing 3 tablets, 4 tablets are all gone. So we have very good reproducible thyroxine these days. We effectively ask our patients to follow the empty stomach without any option. So we don't give them an option of taking coffee within half an hour, breakfast within 1 hour. We enforce it thoroughly and we get reproducible values of TSH. So most of our patients fortunately do this and their TSH doesn't change at all. And we do just 6 monthly or yearly monitoring of their thyroid function. Again, as we discussed earlier, ma'am, the most possible autoimmune hypothyroidism, full-fledged, when people are on 100 micrograms of thyroxine and they've been established for some years, it's highly unlikely we will be able to stop these. So these are long-term medication. If you're suspecting lifelong medications, yes, less than 5 to 10% of individuals may improve. There is a chance, but it will be more obvious in your thyroid function tests at all. If you've got any doubt, then drop back 50% of the dose. You will be making sure that whether these patients are needing it or not. Never ever stop it completely and let them go because they might not turn up for follow-up. So if somebody is on 100, then you probably just, if the patient is insisting to stop it and see, then you might be able to pull it back. But most thyroxine administration is a lifelong therapy.
This is just adding on to the previous questions which you clearly explained. Now, if you feel someone is unnecessarily taking thyroxine, how long would you stop and get a thyroid test done so that they don't get further confused?
If there is no clinical indication and they are on thyroxine, I'd probably stop it for 2 or 3 months, get them back for follow-up, and also warn them of the symptoms of hypothyroidism, as I mentioned earlier, because that helps a patient to identify the symptoms and watch out for the symptoms. Otherwise, they'll be sitting at home with full-blown hypothyroidism when they get back to you at 3 months. So tell them, and you can safely stop the thyroxine in most patients, and as long as you're going to get the patient back and recheck them again. So that's not a big issue at all.
And again, add on to the previous question of a patient found hypothyroid during pregnancy starting thyroxine. Yes, like Dr. Muthukumaran said, yes, that's no reason to abort the child. But in today's litigant world, you have to explain everything and put it in writing. The risk stays with the parents. They have to take the risk because you have to tell them, because you can't, we all have to act as doctors and not God. Of course, we want all our patients to do well, but we have a limitation. So it's very important in today's litigant world, you have to tell them, yes, it's not like this, but because, even in normal pregnancy, 5% of children could have some problems, some congenital issues or whatnot. So keep, there is a child who is born with an unrelated issue. Our own colleagues will let us down and tell them, see, it was because of thyroid, it was started. At that stage, for their fault, they should not come and question us. So at all times in today's litigant world, we have to protect ourselves, put everything in black and white on the paper. And the risk, involved stays with the patient. And I think we have had,
Dr. Bharat has got half the
yeah. I think we have had an excellent session. It was so interactive that I think we overstepped the time. I think we should congratulate Dr. Muthukumaran for an excellent lecture, very eloquent. He went through the whole gamut of cases. And one take-home point which you all could take from his lecture would be that don't interpret any thyroid function report without knowing the history of the patient and the background. Someone comes and gives the function, just a report. The second point would be, you have to treat the patient, the individual. Don't treat the numbers. 5, 6, 7. You have to take it in a holistic manner. And thank you so much, Dr. Muthukumaran. And we now go on to the second part, management of hypothyroidism by Dr. Bharat.
Thank you, sir. So before we start the case-based discussion, I would request delegates to occupy the front seats so that we can have a fruitful interaction. I think most of the case scenarios have already been discussed by my previous speakers, Dr. Murthy sir and Dr. Muthukumaran. I have specifically put this front theme as numbers 9, 2, 4, 6. You can see the slides because we have been discussing only about the numbers here, isn't it? And many times I've seen there are two scenarios which I commonly encounter every day. One is a patient who is started on levothyroxine without much of indication for a TSH of 5, 6, or 7. And the other scenario is a patient who was having a TSH of 100, started on levothyroxine. thyroid function after 2-3 months coming at as 2 or 3. The TSH comes as 2 or 3 and the thyroid tablet is stopped. So both kinds of things are happening, and I'm at least stopping for at least daily. I'm stopping thyroxine for one of my patients because thyroxine is also one of the most commonly used endocrine drug and one of the most commonly abused endocrine drug. So with this, I'll start my first case. This is a patient one. So whenever we talk about medicine, we always talk about primum non noser, and many times what we see is we miss the forest for the trees. Just to highlight this, I have included this patient. A 47-year-old lady, housewife, no significant past medical illness, complaining of lethargy, decreased appetite, weight loss 3 kgs, nausea, dry skin, hair loss. So most common kind of complaints that we see in our day-to-day practice. Menopause at 40 years of age. She had a BMI of 24, BP 170. She had dry skin, mild periorbital puffiness, delayed deep tendon reflexes. So apart from that, the systemic examination was not having any abnormality. So as a part of routine evaluation, this patient underwent these tests. Hemoglobin was 10.2, fasting sugar, lipid profile, renal, liver function, urine routine, everything was normal. TSH was 5.2. The normal cutoff up to the upper limit was 4.5, and the free T4 was very low, that was 0.45. Actually, a free T4 of 0.8 to 1.7 is the normal limit, and 0.45 is very low for this cutoff. The antibody test was also done, which was normal. So from this, I would like to know what it should be our approach. So TSH on the slightly on the higher side and T4 very low. So naturally, what happens is that diagnosed as hypothyroidism, because we have always read that TSH is high, T4 low means it's a hypothyroidism. And she was started on levothyroxine 50 microgram Moody. After 2 weeks, patient lands in emergency room with increasing weakness, nausea, recurrent vomiting, and giddiness. After 2 weeks of starting levothyroxine, that time the BP was 80/60. The sodium was 124, potassium was 3.8, renal and liver function tests were normal. So why after levothyroxine this patient had this issue? So that time the serum cortisol was checked because she had a low BP, she had hyponatremia, hypotension. Serum cortisol was 6.8. So again, the cutoff, usually we see a lab cutoff of 4 to 20 as a normal serum cortisol. So according to this lab cutoff, serum cortisol is normal, but we should not interpret. In endocrinology, we don't interpret based on the normal cutoffs given on the right side of the column. Remember that cortisol, thyroid function tests are always interpreted in the background of the clinical scenario and not seeing the lab cutoffs. So this patient landed up in emergency room with a hypotension, hyponatremia, and she is in a shock. In a shock, what we expect is a increase in the cortisol level. The cortisol we expect is at least 20, 25 kind of a thing, not a 6.8. So a normal cortisol for a shock, that means the cortisol is really low. So don't interpret with the lab cutoffs. It's interpreted in the clinical context. So ACTH is normal. Again, you can say ACTH is normal, but what we expect is for a low cortisol, we expect the ACTH to go high. That is a physiological response that we expect. But ACTH is not increasing for the low cortisol. That means ACTH is also low. So though the lab cutoffs are different, the interpretation in the clinical context is this patient has a low cortisol, low ACTH, and a low prolactin also. So what it finally indicates is that this patient is having a panhypopituitarism because she has a low cortisol, low ACTH, low prolactin. And if you go back to the lab, the thyroid function value, see, for a very low value of free T4, we expect the TSH to be around hundreds, in at least 80, 100 kind of thing. That's what Dr. Muthukumaran was telling. TSH and T4 has a log linear relationship. Even for a mild reduction in free T4, TSH will increase 100-fold. For a significant reduction of free T4, we expect the TSH to be much higher. But here the TSH has not increased to that level for that low free T4. So this patient has a central hypothyroidism instead of what we thought as a primary or a thyroid dysfunction. So this patient had a panhypopituitarism and a central hypothyroidism. And in a central hypothyroidism, it's mandatory that we replace the glucocorticoids. Otherwise, if we replace thyroid alone in this patient, the cortisol metabolism will increase and the patient will develop hypocortisolism. So the interpretation is done with the clinical context. And even if you go back to the history, you can see that the patient had weight loss, which we don't see in hypothyroidism. The patient has nausea, which we don't see in hypothyroidism. So weight loss, nausea, these things give us a clue that this patient might be having something else. It's not the routine garden variety primary hypothyroidism that we see. So the take home message from this is all high TSH need not be a primary hypothyroidism. If pre-T4 is very low, expect a very high TSH in primary hypothyroidism and not a borderline elevation of a TSH. And history of weight loss, premature menopause is another history which I also forgot to mention, because the patient had a history of menopause at 40 years of age, which is a premature menopause. Again, that says that these are not things that we commonly see in a primary hypothyroidism unless the patient has got some other endocrine involvement. So this is one thing which I wanted to highlight in this. Moving on to my second patient, 24-year-old lady, history of hypothyroidism for 10 years, and she has been on 200 microgram of levothyroxine. She has heavy periods, constipation, tiredness, fatigue, mild weight gain, everything is there. General evaluation, thyroid function TSH comes as more than 150 and free T4 is quite normal. Again, as Dr. Muthukumaran pointed out, this patient had a normal free T4 but a very high free TSH. Remember that free T4 is a hormone with a shorter half-life, so it will vary very rapidly with a few days of drug intake, whereas TSH is a hormone with a longer half-life. So TSH, glycoprotein hormone, so TSH varies only when you take thyroxine for a longer period of time at a regular compliance. So this patient has been taking thyroxine for some days or for a few weeks before coming to the clinician, so that we check the thyroid function. We see that a free T4 is normal, but TSH will not come down unless the patient has been very compliant and regular with medication. So many times what we do is we just see the TSH, we hike up the dose from 200 to 250, 250 to 300 like that. When we go back to the history and ask the patient will definitely tell that for the past 3 weeks only I have been regular. Before that I went to my hometown, I forgot to take medicine. So many other stories will come out. So treating the patient in a hypothyroidism needs a regular reinforcement for the patient during each visit. I always insist the patient to bring the bottle of levothyroxine every time when they come to my office visit, so that I check specifically whether the same dose is what I have written is taken by the patient or not. I even ask the patient how many tablets are remaining when you bought it. I even ask them to show the bill. Why these things have to be done is because knee-jerk response will be to increase the dose to the next level, and the patient won't be taking that regularly. There's no point in doing that thing unless we go to the history properly. So the main reason for a high TSH and a normal T4 is a non-compliance with the levothyroxine medication. And levothyroxine and interference or absorption with certain malabsorption due to certain reasons. Nowadays, there are some YouTube videos showing that if you take methi water along with thyroxine, that will cure your hypothyroidism. So some of my patients have started taking methi water along with levothyroxine, and I have seen that the thyroid function test actually going very bad with those patients. So you have to specifically ask these kind of histories. So it's not only that you update your endocrine books or medical books, you update the YouTube knowledge also. So that what patient comes out from the YouTube, what patient learns from the YouTube, you should be able to understand and ask the patient. I have asked specific history from the patient, and patient used to tell that I take methi water along with levothyroxine. So this should be ensured that the patient takes the medication, no calorie food intake for 45 minutes at least. This is a recommendation. So I can tell you the list of things which can cause a an elevated TSH level with a normal free T4 on an apparently patient saying that, okay, I am taking thyroxine very regularly. So you can have so many things like patient may be taking iron, patient may be taking calcium along with the levothyroxine. Some patients may be taking some Ayurvedic preparations, homeopathic preparations along with levothyroxine, thinking that those things have to be taken together. So these things quite commonly happen. You can see that iron, when it's taken along with levothyroxine, how it increases the TSH value. So after injection and before injection, and even the calcium preparations, they will reduce the T4 levels, they will increase the TSH value when it's taken with levothyroxine. So high TSH on therapy, dose increase is always not required. Go back to the history, go back to the medications, ask them to bring the medicines, show the medicines, even they should be showing you the bill properly so that they have bought it recently. Sometimes they would have kept a old stock of levothyroxine at home 2 years back, they will be starting using that levothyroxine. Those things and all happen quite commonly because it's a commonly treated condition, and commonly I would say that these patients have to be taking lifelong levothyroxine. So they'll be doing some mistakes at their point of time at time and again. So detailed history is the most important thing. I would say that every visit we should ensure that they take it properly. So coming to the third patient, again 30-year-old lady, married 2 years, overweight, irregular periods. But this time she's saying that the LMP was 25 days back. She's having hypothyroidism on 100 microgram of levothyroxine. So as a part of routine evaluation, thyroid function test was done. And you can see that the TSH is 0.2 and T4 and T3 are on the higher side. It was a total hormone. Total hormone is higher. Total T4 is high, total T3 is high. TSH is 0.2. So generally what we think, what we see when we see such kind of report is patient is getting higher dose of levothyroxine because the TSH is 0.2. So the natural tendency for us is to reduce the dose of levothyroxine from 100 to 75 micrograms. Generally, we get a knee-jerk kind of a response. We see the TSH and we get very panicky with the kind of a low TSH. And what happened is that the patient's levothyroxine dose was reduced to 75 micrograms. So this patient didn't get the periods even after the reducing the dose. So after 6 weeks time, the patient repeated the test on herself, and that time you can see that the TSH went up to 9.25 and the T4, T3 or pre-T4, pre-T3 are normal now. So the important thing is the patient missed the periods and the pregnancy test was positive. So many times what we do is that in a patient with a reproductive age group who is planning for pregnancy, we see the TSH, but we don't suspect that the patient might be pregnant and she might be unaware of the pregnancy. Even with the early period of pregnancy, the TSH might go low because of the HCG effect, even before confirming the pregnancy. So this happens, and if we reduce the dose of levothyroxine for them, you might end up having a higher TSH after 4 or 6 weeks, and the patient might go into a miscarriage because autoimmune hypothyroidism has a risk of early miscarriage within 12 weeks of gestation. That's the reason we always hike the dose of levothyroxine as a patient's pregnancy is confirmed. So dose adjustment for levothyroxine done cautiously in women of reproductive age group after carefully going through the menstrual history. And early pregnancy can have a physiological TSH suppression due to HCG effect. I generally, this is not given in books, but I generally tell the patient, suppose this patient comes to me with a TSH of 0.2, I tell them, you can reduce the dose of levothyroxine provided you get the next periods, because doing it in the follicular phase, dose reduction will not hamper the TSH value because she is very sure that she is not pregnant during that time. But if you do it at 25 or 30 days of after the periods, might be possible that the patient might be pregnant and they might end up with a higher TSH after the subsequent visit in the next 1 or 2 months. So preferably do it in the follicular phase in this kind of a situation when the patient can be pregnant and she may be unaware of that. So my fourth patient is 35-year-old lady, because pregnancy hypothyroidism is a very commonly asked questions. So there are a lot of queries, lot of confusions in this. Married 8 years, trying to conceive for the past 3 years, has come for a second opinion on the thyroid function. and she is clinically euthyroid, no goiter. She has oligomenorrhea. TSH is 4.4 and T4, T3 are normal. So nowadays there is we go by the antibody levels, especially during pregnancy and infertility situations. So the antibody test, the thyroid antibody test is positive. That indicates that the patient may be having an autoimmune thyroiditis. But at present the TSH is 4.4. So what will be our position in this? Whether we will start treatment or whether we follow this kind of a situation is a question. So menstrual irregularity and hypothyroidism, they go very commonly, like hypothyroid female around 30% can have menstrual disturbances when compared to euthyroid female. And infertility also, we know that 30% contributed by female factors, 30% by male, and 20% by both, and 15% can be idiopathic. And women with female factor infertility are more likely to have positive anti-TPO antibodies than the age-matched fertile women. So infertility and subclinical hypothyroidism, there are so many randomized control trials. Some gave a good result with the levothyroxine therapy, but most of the trials have shown that if a person is having a positive anti-TPO antibody and if the TSH is above 2.5, they might be benefited by giving a levothyroxine therapy. That might be helpful in having a good fertility. So that is the latest guideline or the recommendation. So evaluation of TSH is recommended for all women seeking fertility treatment, and levothyroxine is recommended when there is a overt hypothyroidism. Of course, if the TSH is going to be 10, no one is will be bothered to start levothyroxine, but at a 4.5 or 4.6, we may be hesitant to start levothyroxine for them. But if the antibody test is positive, if there is a good autoimmune history is there, definitely levothyroxine therapy is indicated to bring down or keep the TSH at around 2.5. So subclinical hypothyroidism who are also undergoing IVF ICSI should be treated with levothyroxine, and you try to maintain the TSH below 2.5 in these patients. But if the antibody test is negative, suppose this lady has no history of infertility, she comes to me for a routine follow-up, she is planning for pregnancy, her TSH is 4.4 and antibodies are negative, I would not start levothyroxine for her. If she is married only for 6 months, 1 year, trying for pregnancy, I would ask her to recheck the TSH after 4 to 6 weeks from a different lab, and I'll proceed according to both the values. But this lady has come for infertility and antibody is positive, I would like to start treatment for her. So the same patient, she is coming out after some time, she has conceived with the usage of levothyroxine. Now she is taking levothyroxine. She has a TSH of 2.2 in between. Then again, this visit, she is having a TSH of 4.9. So this can happen, as already pointed out by Dr. Muthukumaran and Murthy sir, that TSH might go low during the first trimester of pregnancy and it might increase after the second trimester. As the weight increases, TSH might increase. So you might go for a higher dose of levothyroxine at the end of second trimester. By 20-25 weeks, there might be a requirement of hike in dosage. So anticipate this phenomenon, tell the patient that you might require a higher dose of levothyroxine, and we never stop levothyroxine during pregnancy. Once it has already been started during pregnancy, we just monitor the TSH, keep the TSH between 0.2 to 2.5 or 0.2 to 4, depending on whether the patient is having a positive antibody or a negative antibody. So the guidelines have changed a little bit recently. The 2011 guideline was very strict in these aspects. Like it should be below 2.5 always or below 3 always during second and third trimester, the TSH cutoff. But the recent guidelines, they have included larger number of data, and they have shown, as Dr. Muthukumaran pointed out, that Indian TSH values have always been higher during each trimester, even in normal Indian women. So the cutoff of 2.5 or 3 is not applicable for all the population. Many times I have seen patients getting levothyroxine, even a 70-year-old lady getting a levothyroxine therapy, started on levothyroxine for a TSH of 3 or 4, because this 2.5 has been somehow it has entered into our minds, and for from birth till death, we are keeping a same cutoff of 2.5 for every individual. I have seen people coming from Western countries started on levothyroxine at a TSH value of 3.5, saying that you have to keep the TSH at below 2.5 at 50 years of age. So I don't think that is quite a reasonable thing. We are making everyone as a hypothyroid patient by starting levothyroxine for them. So for Indian cutoff, what they have recommended now is, if it is more than 10, definitely you start. Less than 2.5, you need not go for any treatment. Between 2.5 to 10 is the question for us. Between 2.5 to 10, if the antibody is positive, if the patient is going treatment for infertility, going for IVF, ICSI, start treatment if it is more than 2.5. And if it is antibody negative, she is coming for a routine follow-up, she has no history of infertility, then you can wait, you can start levothyroxine only if the TSH crosses above 4, and even after that you check the TSH in different labs at a gap of 1 month or 6 weeks, then you go for a therapy rather than going suddenly as a knee-jerk response starting levothyroxine for them. And it's ideal to maintain it below 2.5. Having said this, levothyroxine therapy is not going to harm. It's after all going to improve the option of retaining the pregnancy during the period. So if you start levothyroxine for them, every 4 weeks you monitor till mid gestation, and once at near around 30-32 weeks you check the TSH. Generally, we don't do the TSH after 32-33 weeks. If 32 weeks TSH is quite okay, we ask them to continue that dose. Many times what we do is we reduce the dose. We should not be doing that. If the TSH is within the normal range, continue the same dose. And many times what we should be doing is that these are all so dose of levothyroxine postpartum is the next question, because that question was also asked. So if the patient has been on a levothyroxine before pregnancy, go back to the previous dose of levothyroxine, to the pre-pregnancy dose once the delivery happens. But sometimes we would have started levothyroxine for a patient of TSH of 3.5 or 4, and that dose would have been continued during pregnancy. So the patient would not have had any history of hypothyroidism in the past, and the thyroid function test would have been normal in the past. In that kind of a situation, you can carefully bring down the dose of levothyroxine, monitor the TSH level every 6 to 8 weeks. At one point of time, you can stop levothyroxine, but always tell the patient that even if I stop levothyroxine, you should come for a follow-up at least once in 2-3 months, and you should check the TSH for the next 1 year, because she might again go into hypothyroidism. Many times that is not being followed. They are levothyroxine stopped, after 6 months they come with a TSH of 100 or 150. So that should not be the situation. So coming to the only 2 cases I would have. One is a 14-year-old boy brought by parents for excess weight gain. Weight is at the 97th centile, above 97th centile for the growth chart, and height is at 75th centile. He has acanthosis, central obesity, no goiter, systemic examination is normal. Mother, if you ask history, many times they'll say, I am taking levothyroxine for 5 years. But if you ask them what was the previous TSH level, what was the first TSH level, they won't remember. They will say that the first TSH level was 4.5 for which levothyroxine was started. That may not be the true history. Actually, that may not be the reason or ideal correct reason for starting levothyroxine. So the mother is telling that she has been on 25 microgram of levothyroxine. So this boy, they have already done a thyroid function, because for every obesity nowadays we attribute thyroid as a reason. We blame thyroid as a reason for obesity. As already pointed out, TSH, a gross elevation of TSH might increase your weight by not more than 2 or 3 kgs. So gross obesity of 97th, above 97th centile and all, you cannot attribute to hypothyroidism alone. So the TSH for this boy is 6.5 and the free T4, free T3 are normal. So the mother attributes, every time the mother will tell that, okay, the thyroid is the reason for weight gain and please start thyroxine treatment. As if the thyroxine treatment is going to do wonder for this boy. So this is a kind of a very subclinical hypothyroidism in a child or adolescent. And you can very well say that there are lots of data where when you carefully follow these children without giving levothyroxine, most of them will turn out to have a normal thyroid function after a period of time. And we should always remember that only these are some indications where you might require treatment with levothyroxine in an adolescent, where a subclinical might progress to overt hypothyroidism, especially in a female very high TSH level, positive autoimmune antibodies or positive family history of autoimmune disease or presence of goiter. And you can see that obesity itself might push the TSH to the higher level. This is called obesity induced alteration in the central thyroid. Many times we think that TSH is the reason for obesity, but the reverse is true. Obesity is the reason for the elevated TSH. Obesity may cause hyperleptinemia, elevation of TSH. Sometimes T4, T3 also might be elevated. So ask the boy to lose weight, the TSH will automatically come down and there is no need of levothyroxine therapy. And this is just to highlight that how to approach a child or an adolescent with a subclinical hypothyroidism with a TSH of below 10. Always recheck, always do the antibody test, always see that there is a rising trend of TSH, confirm it before starting levothyroxine therapy. So the take home message is regular follow up and weight reduction measures are alone enough for this kind of children. Again, another patient is a 72-year-old lady with a type 2 diabetes hypertension of 10 years taking treatment regularly. When a master checkup was done, TSH was 8.2 with a normal free T4 and free T3. HbA1c was 8.4. She has tiredness, weight gain, hair loss, bilateral knee joint pain. Many times, all these things will be attributed to hypothyroidism, though these are vague symptoms. So whether this TSH requires treatment is the question. At a TSH of 8.2, we will always have a tendency to start levothyroxine therapy for a patient, but most of the times it won't be required because treating elderly individuals with a levothyroxine, you should be again very cautious because unnecessary use of levothyroxine actually increases the mortality, increases the cardiovascular risk for these individuals. So recheck the recheck the TSH value. If the TSH is consistently increasing and if the antibody levels are high, if the patient's symptoms are very consistent with the hypothyroidism, not like vague symptoms of fatigue, which can happen due to uncontrolled diabetes itself, never start levothyroxine for these individuals. Again, in frail older patients, you should be again very cautious. Most of the things say that you should just observe. You need not treat. Even in healthy individuals, you can treat provided you are having some evidence to say that the TSH is increasing. But in frail older individuals, most of the times, if the TSH is below 10, don't treat them. If the TSH is even at 10 or above 10, 11 kind of thing, you just observe. Unless it's increasing, don't treat them. Or even if you want to treat them with a lower dose, not that 1.6 microgram or 2 microgram dose, maybe at 0.3 to 0.5 microgram dose, and monitor the TSH closely. Keep the TSH at around 3 to 4 or 5. No, don't bring the TSH below 2 and try to keep it because that might push them for a higher risk of morbidity and mortality. So, 4-step approach for a hypothyroidism management. Lab results should be very reliable, reproducible, with a minimum inter-assay coefficient of variation, and unambiguous results should be there before starting treatment. Clinical features should be concordant with the proven causal association. Not every clinical feature you can attribute to hypothyroidism. Goals of treatment should be clearly defined. What TSH I am going to maintain and what is the patient's expectation. Patient may be 100 kgs weight, they might want to come to 60 kgs weight with the levothyroxine therapy. That may not be possible. You should tell them clearly that this is not possible with the levothyroxine therapy. And comorbidity should always be taken into consideration, especially in extremes of age, in coexistent medical illness, in polypharmacy, and in hospitalized patients. Thank you.
Take the questions over coffee. Yeah.
Any questions for Dr. Bharat? Yeah.
Yeah, the Murthy water or something. What about the-
Plain water.
They come for with obesity and with hypothyroidism, we ask them to lose the weight. So most of the ladies, they start with honey water or
Honey water.
plain water, lemon water, and ginger garlic water.
Plain H2O. Simple plain H2O is the
So
only.
when can we take this kind of plain water? After taking the,
45 minutes is the recommended time. you should give a gap between the levothyroxine therapy and any other calorie intake. This is the latest recommendation. Minimum of 45 minutes gap should be there. And if you are going for a fasting kind of thing, many times people come now with Ramzan and they will ask, morning I cannot take levothyroxine. So that kind of situation, I asked them, while you break the fast, you take levothyroxine first, then wait for 45 minutes and go for this thing. Sometimes that we have to tell them.
Thank you so much, Dr. Bharat. There have been two very important topics. So, time constraints are there. Both Dr. Bharat and Dr. Muthukumaran will be available during the day, and you can catch up with questions on them. Thank you so much, Dr. Bharat, for an excellent session. And thank you, organizers. It's been a privilege and pleasure to be part of this workshop. Thank you so much.
Thank you, sir, for your wonderful time, and thanks for taking the workshop in a lively manner. So we'll move on to the next session, the special symposia that will be on the cardiorenal metabolic syndrome. To start with, I'll call Dr. Arpal Singh to chair the session. And the first speaker will be Dr. Abraham Oman, who will be speaking on the cardiology perspective.
So good morning, everyone. Firstly, I'm thankful to all the organizers who organized such a beautiful meeting, and this in COVID era. This is our new start. And session is very important. It's a cardiorenal metabolic syndrome. Even UKPDS study said that complication got reduced if we maintain a stricter glycemic control, but cardiac was still a question mark there. We couldn't, all the drugs which are upcoming are having the CVOT trials, and cardiac is very important. So we have with us our first speaker who will be talking on cardiology perspective. Though Dr. Abraham Oman doesn't require an introduction, but still as a ritual, I would like to say a few words about him. He is MD, DM card, DNB, MNMS, SCA, and FACC. Fellow of American Cardiology. He's a professor. Sorry. So he's a consultant cardiology in Apollo Hospitals, Greaves Road, and also in Toddiarpet, and also in Sokarpat, which is Apollo Hospital. He's very, very active, which all know, in various presentations, and he's presented scientific papers at American Heart Association and European Society of Cardiology scientific sessions. With this, all over to you, Dr. Abraham Oman.
Can I have the first slide, please? So, good morning, everybody. First of all, I would like to thank the organizers for giving me this opportunity. I'm told that Dr. Georgie has some emergency, so we will tweak the timing, and then I will go a little slow, and Dr. Krishna also would join us for a discussion, and we'll finish by 11. So my topic is cardiorenal metabolic syndrome, the cardiology perspective, and I tweak it a little bit for a cardiologist perspective on both. So these are my disclaimers. The content of this presentation is meant for healthcare professionals, and the views and opinions are mine alone, not of the organizers. And these are my disclosures. So let me start, even though the crowd is not that heavy. Like it's always nice to see a picture of a beautiful girl, which will jolt us from our lassitude, if so. And this is Keira Knightley in the movie Anna Karenina. And you would be asking, what is Anna Karenina doing in cardiometabology symposium? And this is because of what is known as the Anna Karenina principle. And Anna Karenina principle is being used and is part of PhD. Many PhD theses has been written on this in relation of Anna Karenina principle and science. And what is it? Because there are many first opening sentences, about A Tale of Two Cities or Moby Dick, etc. But the first sentence of Anna Karenina says so. Happy families are all alike. Every unhappy family is unhappy in its own way. So what does this mean? Tolstoy here meant that for a family to be happy, several key aspects must be a given, such as good health, financial security, and mutual support. And this is true for science and medicine also. And especially in a diabetic universe, multiple factors must gel in for a happy, healthier patient and a satisfied doctor. So this is the Anna Karenina principle, because if you have one alone, you will not have a happy patient. And what are the different components to make the diabetic or metabolic patient happy or healthy? They include glycemic control. And you can see here, time in range, long-term compliance, hypoglycemia, HbA1c as part of glycemic control, metabolic risk, visceral adiposity, insulin resistance, energy metabolism, and cardiorenal risk. And cardiorenal risk, there are many things, but cardiologists are very fond of acronyms. So we have heart failure, kidney disease, they're not acronyms, but MACE, major adverse cardiac events. And this is a standard endpoints for many, many studies. Then we coined a new term, MALE, M-A-L-E, major adverse limb events. Then we coined another, MARE, major adverse renal events. Then we went on one step further, MACHE, that's M-A-C-C-E, major adverse cardiac and cerebral events. And finally, MARCE, M-A-R-C-E, major adverse renal and cardiac events. So all these things together form the family or the components to make a happy diabetic patient. So let me discuss one case, a true case, the importance of cardiometabolic renal syndrome is that, like, at least 1/3 of the people in this audience itself may be already part of this continuum. Most of our patients are part of this continuum or well set in the continuum, and many of our own relatives may be part of this continuum. So let us see this patient. This is a real patient who came to me a few days back. So 65 years old male, diabetic for 10 years, hypertension 5 years, had a PTCA to LAD 5 years back. His BMI is 31, he snores. Creatinine in 2018 was 1.8, now is 1.7. Some values have shown 1.5 also. So EF is 38%. He says he's clinically well, and his only intention was to get a clearance for eye surgery. It was atorvastatin 10, telmisartan 20, metoprolol 25, aspirin, ticagrelor. Ticagrelor is not needed after 5 years, but it was on ticagrelor. It was insulin, metformin, sulfonylureas, and DPP4 inhibitor. And LDL was 89, HbA1c was 7.9, urine protein 2 plus, BP of 150, 94, and 80, heart rate of 80. So this patient was very happy with the treatment he was receiving, and he considered himself very healthy. So let me have an audience question, and we'll have a raise of hands, and because I don't think we have the voting pads. So my question is, how will I approach this patient? For each thing, I would like to have a show of hands. Do nothing. He says he's clinically well, and if something is going well, I would rather leave it alone. And he's on guideline-directed therapy. How many think that he's well on guideline-directed therapy? Can I have a show of hands, please? Nobody? Okay. Please show the hands, because otherwise it would be it would not be interesting. Second is, again, do nothing. He's denying symptoms, but we know that he's not on guideline-directed therapy. Then C is increase statin dose and add SGLT2 inhibitor. Or D is counsel the patient and have a multidisciplinary approach, including cardiologist, nephrologist, diabetologist, or endocrinologist, and sleep specialist. So how many for B? Nobody. How many for C? Okay, and how many for D? Okay, equal this thing, but I would personally go for D, and I'll try to because his creatinine, his GFR will be around 40, And he has basically was very happy. Interventional cardiologist was seeing, and then the interventional cardiologist was happy because he was not having any cardiac symptoms, but he has multiple problems. So next question is, what is the target LDL in this patient? 55, 70, 30, and 45. I'll go back to the case. So what do you think? He has got diabetes, he has got hypertension, he already have CAD, body mass index is 31, creatinine is 1.7, EF is 38, his LDL is 89, and he is on atorvastatin 10. So like A is 55, B is 70, C is 30, D is 45. So how many for 55? How many for 70? How many for 30? Nobody. And anybody for 45? Okay. So I will again elaborate on this. So one of my key take-home message, if I have any, is that the previous topic, there were many discussions about myths about hypothyroidism and TSH. But the biggest myth is the myth of a low-risk diabetic patient. There is no low-risk diabetic patient as far as cardiac condition is concerned. That is the biggest myth, and that myth creates more problems and more deaths than most of the other medical myths put together. Why? Because ESC says that moderate risk. Here, young patients, short duration diabetes, age less than 50, without other risk factors, also come under moderate risk. Now let us look at very high risk. Patient with diabetes, established cardiovascular disease, or other target organ damage. That is very high risk. And high risk is more than 10 years without target organ damage, plus any other additional risk factors. And it would be challenging to find a diabetic patient without an additional risk factor. And he or she automatically becomes a high risk. So our patient actually is very high risk because he's got established cardiovascular disease, has got target organ damage, and 3 or more risk factors. So it's not or, he's got and everywhere. So the European guidelines say that their target of high risk, very high risk patient is 55. So somebody had answered 55, it would have been right. But the Lipid Association of India went one stretch forward. I don't know whether you can read this, but here, CAD with more than one feature of very high risk group. That means somebody has got coronary disease, and along with diabetes and 2 risk factors. So established coronary disease, diabetes, and 2 risk factors, the patient becomes extremely high risk as far as Lipid Association of India is concerned, and their target is 30. So the patient which walked into my OP thinking that he is low risk, he is fine, actually comes under very high risk if you go by European Society of Cardiology, or extreme high risk if you go by Lipid Association of India. So this is something which we have to know. Again, back to metabolic part. This is a paper published about 6 months back, and this is about the metros in India. And if you're 20 years or old and obese, and it is said that more than 3/4 of our teenagers are obese. So their lifetime risk of getting diabetes is about 87%, and 50% of that lifetime, they would have diabetes. So that is like sleeping with the enemy or sleeping with the devil. It's like the most dangerous combination you can have. And just imagine our children or grandchildren or nephews or our children's classmates, or if we just go outside of school and watch during the lunchtime, majority of the children are overweight or obese. And the chance of them getting diabetes or metabolic problems are very, very high. So diabetes from a cardiac perspective affects the pump, that is heart failure, plumbing, that is the coronaries or cerebrovascular events, and the filter, that is the kidneys. So since the nephrology part is not, Dr. Georgie has an emergency, I would spend little more time on the kidney part from a cardiac perspective. So another important thing, as I mentioned before, the low-risk diabetic or only diabetes with no other risk factor is extremely rare, especially in Indian scenario. In this study, about 6% had only diabetes and no risk factors. The most important thing here is about 50% plus had more than 3 risk factors, and they come under very high risk category. And more the risk factors, more chance of death or comorbidities. And again, this is one slide I love, because like when I ask my fellows or even MD trainees or DM trainees or DNB trainees, I ask them, if you have a diabetic patient, what is the cardiovascular complication, or what is the complication the patient may most commonly encounter, and what's the major complication? And invariably the answer is coronary artery disease, MI. Is based on the old Hafner's paper in late 90s, which has been questioned, maybe discredited. But you can see here, it is the heart failure and kidney failure, which is the blue line. This is the heart failure of CKD is much, much higher than coronary artery disease. And it is much more fatal than coronary artery disease. Now, it's a little bit about CKD and heart failure. So the important thing is, suppose you have a patient with CKD, and CKD, like stage 3 start from GFR less than 60. So when we think of kidney failure, automatically we think of somebody on dialysis or creatinine more than 5 or GFR less than 15. They are the end stage. But the majority will be into stage 3. And these are the ones who require maximum attention, and like we can prevent events. And in the ARIC study, what they showed was that if you have CKD, the chance of getting heart failure doubles. So heart failure begets kidney disease, and kidney disease begets heart failure. And again, suppose somebody has heart failure, like our patient. EF is 38%, he's otherwise walking, talking, everything. And he thinks that a fantastic treatment has been given by angioplasty. That's very good. But the question is, look at what are the risk factors for his death. That patient's death. They include age, he's not very old, NYHA class, he's not in very high NYHA class, maybe class 2, ejection fraction is 38, low, and diabetes and creatinine. So he has 3 out of 5 risk factors for death, and death is the absolute endpoint. We can talk about any number of endpoints, nothing beats death. And again, about 2/3 of patients with heart failure have kidney dysfunction, and vice versa also. But 2/3 of patients, even with mild renal disease, have cardiac impairment. And in India, 1 out of 3 diabetics have cardiac involvement. That may be a gross understatement. And 1 out of 2 diabetics may have renal involvement. So these are not rare things. Just imagine how many diabetics you have seen in this month, like in March 2021. And imagine 1/3 of them having cardiac disease and 1/2 of them having some kind of kidney disease. And are we doing anything for them? And that is the cardio-renal metabolic continuum. And so some history, we may think that's a new concept. No, it is not a new concept. It's a very old concept. This concept was originated by the father of nephrology, Sir Richard Bright, in 1836. And in 1835, fluorescein, the SGLT2 inhibitor, was discovered, isolated by French people. And it took so many years for the SGLT2 inhibitors to come to fore, and the cardio-renal metabolic continuum or syndrome to get from the shadows into the limelight. And what are the conceptual framework? The conceptual framework is that there are multiple systemic factors like diabetes, obesity, metabolic syndrome, hypertension, amyloidosis, which leads on to sympathetic neurohormonal activation, inflammation, endothelial dysfunction, fibrosis, oxidative stress, all leading on to heart failure and renal insufficiency. And each one will beget the other. So heart failure will lead to renal dysfunction, and renal dysfunction will lead on to heart failure. So what are the problems? What are we all heard about wonderful medical care we have available in India, maybe as good or better than the West. But the problem is what is called as siloed care or compartmentalized medicine. we look only at our particular interest. And this is the biggest problem. It is not even the resource or support issues. The siloed care is the problem. Silo mentality is unwillingness to share information or knowledge between employees or across different departments. This is regarding business modules, but in hospitals and medicine, it's widely prevalent. The typical example is my patient. He never had a nephrology opinion, and even his diabetology endocrine opinion was once a year, and was doing reasonably well. So it was continued so, and was not on very essential medications. And there's a not a new concept. Machiavelli in 1513 had propagated this concept, but we should move away from compartmentalized medicine or siloed medicine. So why all these things came into prominence is because of the SGLT2 inhibitors. And so there's a busy slide again, because no talk about cardiorenal metabolic syndrome would be complete without SGLT2 inhibitors, and some mention about GLP-1 receptor analogs, but mainly SGLT2 inhibitors, because that opened the floodgates and that changed at least our knowledge about this metabolic, renal, and cardiac continuum. And you can see here 3 sets of trials, one on diabetes with or without, or mostly stable diabetics, or without CVD or renal failure, and another on set of in heart failure, and the set on CKD. So I would touch upon the patients with the combination. So empiric outcome at 26% of the patients with GFR less than 60. And so let us look at the patients with diabetes and GFR less than 60. So roughly the creatinine may be around 1.3, 1.4, if I can put a number there, but we have to calculate GFR in every patient. And GFR less than 60, you can see here, the cardiac events reduce significantly, even more than that of a patient with GFR more than 60. So these are patients with diabetes, may have primary or secondary, may have underlying heart disease, but many did not have, most did not have heart failure. And when you look at the cardiac events in these subsets with mild renal dysfunction, and they had great benefit in heart failure hospitalization, death, and even coronary events. Now look at the heart failure trials. There are 3 heart failure trials, DAPA-HF, Emperor, and Soloist. Soloist is the latest. And again, we look at these patients included diabetics and non-diabetics. So there are 3-4 situations here: diabetics or non-diabetics, or having heart failure, and some having mild CKD, creatinine, GFR between 30 to 60 and more than 60. And if you look at their cardiac events, if they have, whether or not they have diabetes, whether or not they have CKD, these they benefited with, they have having heart failure, they benefited with SGLT2 inhibitors. But there was further benefit with in renal aspects also. I'll take a little more time because there's no next speaker, and I was requested to go slow. So again, CKD. So patients with, we all see this patient. When you go back, somebody with proteinuria, somebody with creatinine of 1.2, if you calculate the GFR, if it's like 60, 45 to 60, they are still in stage 3 CKD. And we have tons of them, like all of us have. And patients with CKD, whether they have underlying cardiovascular disease, whether have diabetes, if you add SGLT2 inhibitors, not only the renal events, their cardiac events also come down. And ultimately, we need our patients to live longer, live better, and live without complications. So my patient was in a pseudo world where he thought everything was fine. But if you had noticed that case, he was not on any SGLT2 inhibitors. He was only on a small dose of telmisartan. So that was the mistake. Now, again, from the cardiologist perspective, we all know about it. We have a lot of talks. So every session in diabetes or cardiology or nephrology will have SGLT2, 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 and some GLP-1. And still, what is the state of the state of practice among cardiologists? So I'll talk about cardiologists. So they looked at this 2020 paper, very recent paper. They looked at 4 aspects: knowledge about SGLT2 or GLP, knowledge about when to initiate them, knowledge about the patient eligibility, and knowledge about side effect profile. And 1/3 of the cardiologists, this is a US study, 1/3 of the cardiologists thought that or had absolutely no knowledge in any of these aspects. Not one, all 4. They've had 0 mark in all the 4 subjects. That is bad. And that is why this kind of meeting is important. Now let me come to the endocrinologist. And this is from a diabetes care. So, and they looked at practice pattern. This is a February 20 paper. And they looked at practice pattern from 2013 to 18. And they found that disturbing trend. What was its disturbing trend? Actually, the prescription of SGLT2 inhibitors dropped amongst endocrinologists. It may look funny, but this is the data. Cardiologists, only 3 to 4% give SGLT2 inhibitors. They remain stable. And internal medicine people and the primary care numbers went up a little bit, but we are not doing a good job. So why is that? That is partly because of the so-called siloed care. And again, another paper where it showed that, again, cardiologists, we think that, like, especially the typical example is my patient, that patient and the interventional part was done perfectly. But the 2020 paper by Blaha from Johns Hopkins, and they found that more than 90% of the patients with MS, this is again US, and more than 80% of the patient with chronic heart disease, their patient was not treated according to the new evidence. They got some treatment, but treatment could have been improved. So this is something we should ponder about. So what are solutions for this problem? There are 3 solutions: incorporation into cardiology guidelines, comprehensive cardiometabolic clinic, and a cardiometabolic medicine subspecialty. In India, I would rather call it a metabolic cardiac subspecialty, because diabetes and obesity is so rampant, and they are the best people to drive it forward. So who are the patients? Diabetic, metabolic syndrome, dyslipidemia, obesity, fatty liver disease, early CKD, Western hypertension, family history. All these people, family history of CAD, as all these people, all diabetes, they are eligible for this clinic. Now, out of scope is complex arrhythmias, advanced heart or renal disease, device therapies. And what are the referral pathways? Cardiology, endocrinology, nephrology, primary care, and hospital discharge. Now we'll take a deep breath here and look at metrics of success. We all need metrics of success. We had a recent JCI inspection, and the only thing they asked in the cardiology was, what is the door to balloon time? They did not ask how many of them were going with SGLT2 inhibitors or ARBs, how many of them had a heart rate less than 75, but they were extremely keen on the size, number of stents, and the door to balloon time. And look at the metrics of success here. And this is relevant to our patient. See, blood glucose management, our patient failed. Percent of patient on SGLT2 inhibitor or GLP-1, our patient failed. Weight loss target, failed. Lipid target, failed. BP goal, failed. Patient satisfaction, yes, but it may be a pseudo satisfaction. So we are at a stage, but almost everybody, including the patient, thought that he's having a good treatment. Actually, he had failed in 5 out of 6 metrics of success. And here, this is where the cardiometabolic continuum or cardiometabolic renal clinic or cardiometabolic renal cooperation is needed. And finally, you need, or the subspecialty of cardiometabolic medicine is coming up. It may take some time. This is a subspecialty after endocrine or diabetology or cardiology. And these people will have awareness and training in cardiology, endocrinology, hepatology, nephrology, nutrition, obesity medicine. And in another 5 years or so, it may be a subspecialty in US. So what are the take-home messages? There's a dire need to treat cardiorenal metabolic disease epidemic. It's a huge epidemic going on. Cost effectively. It is the, again, it's not the cost, it is the cost effectiveness rather than the cost. Highly focused healthcare is needed And this is a major challenge of 21st century. Prevention, treatment, and risk factor management of cardiorenal metabolic disease needs a collaborative, less siloed or less compartmentalized approach. And cardiometabolic clinics or cardiometabolic subspecialty may be the future. So this is a business statement: collaborate or perish. Or for our patient, we have to collaborate, otherwise patient himself and our practice may perish. So this is my last slide. I deliberately took some time because to cover the nephrology aspect of it. Knowing is not enough, we must apply. Willing is not enough, we must do. Thank you very much for patient hearing.
Thank you so much, sir. It was a very lucid presentation. And you second last slide, you need to collaborate. You took a very good charge for, describing nephrology also. So fabulous. Any questions for Dr. Ibrahim Oman?
We'll have some time, so Dr. Krishna, you can join in.
Dr. Krishna, please join us for renal perspective discussion also.
Let me start something that in the last 2 days, we've heard some amazing basic science talks coming in, but we didn't do much of the endothelium. So why do you think that the heart and the kidney share this bond that one feeds on the other? Is it the endothelium? Is it?
The answer is multifactorial. I showed one, it's a circulation paper. So there may be a neurohormonal, metabolic, endothelial link between all these things. So we cannot pinpoint on one, but one feeds on the other. That's all I can, because circulation had a beautiful paper which showed that all these metabolic factors come together to have a basic, or what they call pathophysiological changes, which happens, it's a two-way street, and which affects both kidney and heart. And there is like a constant love letter going between heart and kidney. And sometimes it may be deleterious also.
So we on Friday, we had two very elegant talks. One from Sundar, who you know and heard, whose hypothesis is the fuel hypothesis. And then we heard from Dr. Dale Abel on the mitochondrial energetics that are contributing to this whole picture. So what do you think? You think that this whole thing is a fuel thing? Is it?
Possibly, because if you remember that slide, my fourth point was mitochondrium. And somebody asked me about a couple of months back in a talk, so can you summarize heart failure in one sentence? And my sentence was, heart failure is essentially a mitochondrial disease. So there are a lot of work going on, but these are interesting premises. But ultimately, my point is, if you do not practice what we know even at present, like a lot of patients would suffer.
The next question I have is looking at heart failure itself. We know that these numbers are high, right? But there are several predictive scores of saying who has a higher risk of heart failure. Now, as a diabetologist who sees these patients much earlier than you do, what is your advice to me? Do you think that is there something that should I do a heart failure score? Should I do an echo, looking for an EE prime, or what should I do to ensure, besides glycemic control, to ensure that I have started concentrating on patients who may be at risk for heart failure?
Okay, so there was a paper, I think JAMA, which looked at newly diagnosed diabetics with no obvious symptoms, quote unquote, so the so-called low risk diabetics. And most of them did not have other risk factors also, and some of them had. And they looked at the global longitudinal strain. And surprisingly, 22% of this, there's 1 out of 5 had abnormal or low global longitudinal strain, indicating that they had some systolic dysfunction. So the heart failure is like, what is heart failure? Heart failure is not somebody who is huffing and puffing and swollen up, but it is a continuum again. So my advice is, First, any patient with diabetes at whatever stage, whatever age, even if they're 25, we have tons of people with 25 years with MI, and they say, oh, I've been diabetic for 2 months, 3 months of high blood sugars kind of thing. Have the three things, the metabolic part, the renal part, and the cardiac part in perspective. And my suggestion would be a simple echo. Why a simple echo? Because it is cheap, widely available. And I would ask for 4 things. And you also should insist that these things should be done. Look for 1, left ventricular hypertrophy. 2nd, left atrial enlargement. 3, pulmonary artery hypertension. 4, E by E prime is a measurement of end-diastolic pressures. Anything more than 14, remember 14 because it's easy to remember. More than 14 is abnormal. And global longitudinal strain, which is a much better indicator than ejection fraction. Ejection fraction, another 10 years, like 2031 debates may have, we will not be saying about ejection fraction at all, maybe. So, and the important thing is it's available in all the echo machines, in all the reasonable centers and small standard machines in the country, everywhere. But, and it takes about 2 minutes extra, not in a single paisa extra, but you should ask for it. And if that is abnormal, keep a track on the patient. It's not that jump on them and do, but again, they may be a candidate for SGLT2 inhibitors because these are the people, SGLT2 inhibitor cost is going to come down and cost effective. It's better to prevent a thing than treat a disease. So my advice for the heart failure part is simple echo, simple ECG. And if any one of them is abnormal, do a NT-proBNP. And that would give a good idea about heart failure part. The coronary part, again, I am like, we are in the process of having new risk score. There are many risk score. I love what is called as Q-RIS2 because it takes 3 things rather. One is in the South Asian ancestry, 2nd, diabetes, and 3rd is family history into account. And I love that. So I use Q-RIS2. And surprisingly, many people after master checkup, they come out as low risk people. And after you have a Q-RIS scoring, they go out as higher risk people. So this Q-RIS score again takes 30 seconds. Put it in writing and takes exactly 30 seconds extra. And you'll be doing a great service to the patient.
So I have a question. Well, you asked to audience to raise the hand for the answer was D. I vouch for that. But there were a couple of hands raised for choice C also, adding SGLT2. So I think sacubitril valsartan did a fabulous job reducing the heart failure. But with the SGLT2 coming in and the trials like EMPA-REG, which was showing for established cardiovascular disease, and DAPA-HF and DAPA-CKD credence trial. So everything favoring and helping. So what's your take on that? And since diabetologists and endocrinologists have good experience with side effects, you showed a slide where cardiologists are comparing, but then what is the advice to diabetologists and endocrinologists from cardiology perspective?
Yeah, so basically, you may see patients like I showed. You will see because they would have had an angioplasty, ejection fraction around 38, 40, doing well, and they'll be under your follow-up, rightly so. And if somebody has heart failure, anybody right now ejection fraction less than 40% is having heart failure with reduced ejection fraction, and they will benefit by 4 groups of medicines. One is ACE-ARB or ARNI. 2nd is SGLT2 inhibitors. 3rd is beta blockers, and 4th is MRM, melanocorticoid receptor. Simplest is spironolactone, costs nothing again. And if you add all 4, and remember my patient was only on telmisartan 20 milligrams among these 4. If you add all 4, you save 6 years of their lives. And so 4 drugs, 5 mechanisms of action, you save 6 years of their life. And very few treatment modalities in medicine, except for infections also, or non-communicable disease, you have such kind of mortality benefit. And that is where a diabetologist should be a good cardiologist and a nephrologist, And a cardiologist should be a good diabetologist also. So, yeah.
Last question. So I think both you and I are fans of Robert Eccles' proposal that there should be a new specialty of cardiometabolic renal, a new subspecialty. One, can you expand your thoughts on it? And second, just across the stage, you want to start one?
Sorry?
Do you want to start a fellowship?
Again, I'll answer that. See, the typical example is my patient again. My patient, this is a real patient who came to me about 2 weeks back. He would have gained in life, and life is precious, having a cardio-diabetology, cardio-metabolic renal clinic or a specialty. Because we are practicing siloed medicine. We are looking at the numbers and our own passion, and we are missing the broad picture. So I would rather definitely would like to have a subspecialty. Second thing is like there is a lot of distance between the cup and the lip, or if possible, it may be coming up. In US, it will come up in 5 years' time, because we know we have been known for a long time. But now that this thing is, the coronary fixing is not the only thing in cardio. It's an important thing, but that's not the only thing. And like heart failure has got 5 times higher mortality than acute MI. A person getting admitted with heart failure in India, the chance of dying in 1 year is about 30%. If you get an MI and get admitted, chance of dying is 5%. Any kind of MI. So that is how the thing is. Starting, I would love to, but again, long way to go. Yeah, I'm okay with that. Thank you.
Thank you so much, sir. You were a treat for everyone who is listening to you. Thank you so much.
Thank you, sir. Thank the chairperson and also the speaker for taking the session in a lively discussion way. So moving on to the next session. So this session will be chaired by Dr. Y. Sadasiva Rao. So may I call upon Dr. Sadasiva Rao, sir, to the stage. So in this session, the speaker will be Dr. Shashank Joshi, and he will be speaking on the impact of stress on diabetes and metabolic syndrome and evidence-based review.
So good morning, everybody. I must
In the outset, I would like to thank Dr. Krishna Seshadri again for calling me to chair this session of no other person than Dr. Shashank Joshi. And we are just waiting for him to come. Yeah, he will be talking on the impact of stress on diabetes and metabolic.
thank Dr. Krishna, Dr. Arvind, Dr. Prasanna Kumar, Dr. Sanjay Reddy, the whole debate team. And I wish I could be there with you. And, we are surrounded by an entity called stress.
I think
And
he's
today I'm
going
going to talk on a
online,
very
yes.
unique topic of the
So,
link of
Shashank
stress
Joshi
and
does not need
disease,
any introduction.
stress and diabetes,
So,
the untold
well
story.
known. And
So there is no conflict of interest or duality of
Yeah,
interest for this
please.
talk. Our objectives today are to understand stress, to look at long-term consequences of chronic stress, So good morning, everybody. I must thank Dr. Krishna, Dr. Arvind, Dr. Prasanna Kumar, Dr. Sanjay Reddy, and the whole debate team. And I wish I could be there with you. And, we are surrounded by an entity called stress. And today I'm going to talk on a very unique topic of the link of stress and disease, stress and diabetes, the untold story. So there is no conflict of interest or duality of interest for this talk. Our objectives today are to understand stress, to look at long-term consequences.
Sorry for the delay. I think they're having some problem. They're sorting it out. Yeah.
And, we are surrounded by an entity called stress. And today I'm going to talk on a very unique topic of the link of stress and disease, stress and diabetes, the untold story. So there is no conflict of interest or duality of interest for this talk. Our objectives today are to understand stress, to look at long-term consequences of chronic stress, stress and its link with non-communicable diseases, stress and diabetes, ways to manage and prevent stress, nutrition and stress resolution, and a new term called stress adaptogens. So stress and science, despite of tremendous understanding in human biology, medical sciences, we have been struggling with relationship of understanding between stress and disease. The stress word is a very popular term, extremely ambiguous in the medical context. And for this one reason, the subjective experience of stress does not predict elevation of physiological stress mediators. So let us look at some definition and key terms. What is the definition of stress? Oxford Dictionary definition of stress is a state of affair involving demand on physical or mental energy. Health professional define stress as a dynamic condition in which an individual is confronted with an opportunity constraint or demand related to what he and she desires for an outcome is perceived to be uncertain and important. Stress is body's non-specific response.
And,
we are surrounded by an entity called stress. And today I'm going to talk on a very unique topic of the link of stress and disease, stress and diabetes, the untold story. So there is no conflict of interest or duality of interest for this talk. Our objectives today are to understand stress, to look at long-term consequences of chronic stress, stress and its link with non-communicable diseases, stress and diabetes, ways to manage and prevent stress, nutrition and stress resolution, and a new term called stress adaptogens. So stress and science, despite of tremendous understanding in human biology, medical sciences, we have been struggling with relationship of understanding between stress and disease. The stress word is a very popular term, extremely ambiguous in the medical context. And for this one reason, the subjective experience of stress does not predict elevation of physiological stress mediators. So let us look at some definition and key terms. What is the definition of stress? Oxford Dictionary definition of stress is a state of affair involving demand on physical or mental energy. Health professional define stress as a dynamic condition in which an individual is confronted with an opportunity constraint or demand related to what he and she desires for an outcome is perceived to be uncertain and important. The stress is body's non-specific response to demand placed on it. It's a state of threatened homeostasis, as Hans Sly said it very nicely. So the key stress-related terms are homeostasis, a complex dynamic equilibrium that is constantly challenged by intrinsic and extrinsic forces or stressors, process by which bodily functions are maintained. A stressor is any real or perceived physical, social, or psychological event or stimulus that causes our body to react or respond. And the stress response is allostasis. So the way the body functions in a response to an environmental challenge, which is perceived as a stressor, is called allostasis. So typically a general adaptation syndrome in the normal state of resistance or homeostasis is number one, alarm stage, where the stressor disrupts body stability, temporarily lowering the resistance. Resistance stage, where adaptation resources are mobilized to combat the stressor and body maintains a high level of resistance. And third is exhaustion stage, where the body is burnt out of adaptation energy stores by adjusting to stressor and resistance drops below normal. And then, of course, there is also a phase of recovery. What are the different stressors? Well, there is job stress, COVID itself and the uncertainty around COVID. We wrote a nice article. 50% of employees related have some stress related problems. Indian employers rank stress as the number one lifestyle risk factors. Job related accidents are stress related. Absenteeism due to stress has increased almost 100-fold. Marital stress with satisfaction from marriage is directly linked to plaque progression and percentage of plaque. So how do you cope up with stress? We can cope up with stress with physiology and hormonal responses. So obviously, when there is an acute stress response, the salivation decreases, pupils dilate and bring more light to get better visual perceptions, hearing ability increases, blood flows more in the brain and senses sharpen, perspiration increases, respiratory rate, heart rate, blood pressure increase, digestive system slows down, blood supply is diverted to more critical areas, liver and fat tissues release the energy producing substances like glucose in the bloodstream, blood clotting ability increases, immune system activity decreases, urine production decreases, and more blood flows into the muscles and muscles become tense. So the short-term adaptation and long-term maladaptation is done and driven by some neuroendocrine apparatus. The most common one is corticosteroids. Acutely, they provide glucose fuel, increase food-seeking behavior, and chronically, corticosteroids cause hyperglycemia and fat accumulation. Adrenaline or epinephrine acutely increases the pulse rate and blood pressure, chronically will cause arrhythmias and hypertension. And in the brain, the amygdala and hippocampus and the mediators in the amygdala and hippocampus respond with the help of autonomic nervous system for alertness, fight, and fright. And in chronic, there is death of neurons and atrophy. So obviously, when you see the biochemical changes and genetic damage of chronic stress, you have epinephrine excess, corticosteroid excess, insulin resistance with cytokines, blunting of the male hormone, DNA repair goes down, the DNA damage goes up, and oxidative stress goes up. That's typically this thing. So normally, there is a normal allostatic response in which there is a response initiated by the stressor, sustained for an appropriate interval and then turned off. And multiple periods of poverty level of income, non-habituation of public speaking, there will be an allostatic overload. So what is an allostatic overload? Prolonged increased cortisol due to sleep deprivation. Commonly, when you sleep less, what happens? There is an allostatic overload and there is persistent hypercortisolism, and short of stress response, more cytokines are made and more autoimmunity generated. So having good sleep is so crucial and critical. So when we look at stress response and various allostatic overload events, there are environmental stresses all of us face, like work, home, neighborhood. There are individual differences in gene development experiences. And obviously, mentally also we perceive stress, like threat or no threat, helplessness, vigilance, trauma, abuse, behavioral response, personal diet, behavior, smoking, drinking, exercise. And ultimately our body decides as an allostatic response whether we'll adapt to it appropriately or inappropriately based on the allostatic load. And that's the key driver for disease. And this whole allostatic load is fundamentally located in the amygdala, which will hypertrophy and later on atrophy. It is located in the hippocampus, which will atrophy, and in the frontal cortex, which will atrophy. So those are the three key places in the brain: the amygdala, the hippocampus, and the prefrontal cortex. So how does one measure allostatic load? Well, you can simple systolic blood pressure, diastolic blood pressure, indices of cardiovascular activity, waist-hip ratio, index of chronic metabolism and adipose tissue deposition is thought to be influenced by the steroid activity, LDL, HDL, lipid levels, atherosclerosis, glyco-HB, but also DHEAS, a functional HPA axis antagonist, overnight cortisol secretion, is an integrated measure of 24-hour HPA axis activity, and overnight urinary epinephrine or epinephrine activity are an integrated indices of 24-hour sympathetic nervous system activity. So these are some of the key measures of allostatic load. So obviously we can measure disruption of multi-system responses to stress in type 2 diabetes. And when we investigate dynamics of allostatic load in this particular experiment was measured by systolic blood pressure, heart rate variability, interleukin-6, and salivary cortisol. So what is the impact of stress? It's huge. We all know it because common physical symptoms of stress are tension headaches, migraine, dizziness, oily skin, dry mouth, jaw pain, grinding of teeth, backache, tightness of chest, so on and so forth. And obviously when there is stress, you get atopic diseases and asthma, gastrointestinal diseases when there is allostatic overload, coronary artery disease, psychiatric illnesses, and nobody can forget, of course, diabetes. So obviously mental and psychological stress will lead to hypertension. We know high job stress, marital stress, low socioeconomic status, all of them increase cardiovascular disease and mortality and hypertension. And this is data to show that the mental score goes up as the hypertensive stress goes up, and there is a statistically significant association. So clearly we know that chronic stress and affective disorders increase the hypothalamo-pituitary adrenal axis, sympathetic nervous system activity, altered behavior, and will increase the reactivity to stress, which will lead to autonomic dysfunction, insulin resistance, central obesity, inflammation, hypertension, platelet activation, endothelial dysfunction, ovarian dysfunction, bone density coming down, somatic effects. And psychological stress is a coronary artery disease factor. We all know it in cardiac practice, and it masquerades the cardiac symptoms. So obviously, when you look at stress, it has a huge impact on our day-to-day lives. And we know that when there is chronic stress, we get too much of steroids, and it basically makes us immuno-incompetent. There is a meta-analysis of more than 300 independent studies to confirm now that stress affects immunity. And longer the stress, more is the damage to immune system, and elderly and sick are more prone to stress-related changes in immunity. Stress and depression both cause and consequence of diabetes. 20 to 40% of Indians with diabetes have concurrent depression. Stressors reported by diabetics are children's future, family conflict, personal health, financial security, job stress, family health, loss of family member, old age, diabetes, interpersonal abuse, loneliness, and alcoholic abuse. And psychological or psychosocial work stress increases risk of diabetes more in women than men. So obviously, when it comes to impact of stress on diabetes and obesity, job is one of the commonest cause of risk of developing type 2 diabetes, and that's an independent risk factor. And clearly you can see co-occurrence of obesity and work stress. And in COVID times, it is going to go up in an exponential proportion. So how can you actually see this in the smaller children or adolescent children? Well, we know stress is a common risk factor for obesity and addiction. And here in this illustration, you can very clearly see in a model how highly palatable food cues and stress exposures may increase subjective emotions and hunger and activate metabolic stress and motivation in the brain and the body to promote a lot of food motivation and intake, leading to weight gain. So this is something very well known. So stress influences food choices. Stress enhances maladaptive metabolic responses to unhealthy foods, and stress affects mood as well as pro-inflammatory responses to stress. So diet can be linked to negative emotions and stress and inflammation and autonomic nervous system activity, oxidative stress, NF-kappa beta activation, and metabolic response. So stress depletes nutrition. All nutrients are depleted. And poor eating habits do not replace these these various nutrition. And to make it worse, we have comfort food, processed sugars, processed flours, processed sodas, food in high sodium content, and all this negatively influence our nervous system by releasing more epinephrine, increasing our heart rate and blood. So certain foods also suppress immune system like refined foods, sugars, trans fats, sat fats, and processed foods. So clearly, the shorter telomeres with high telomerase activity is associated with allostatic load and impoverished psychosocial resources. And you can see the data is very, very clear here that you can clearly look that whenever there is allostatic load, you will get high mortality. So managing stress is an art. A diamond is just a piece of charcoal. When handled, that stress has to be handled very well. So stress management is an art. It's all about lifestyle. It's all about moderating physical activity and relaxation techniques and social support at an individual level. So clearly you need to ensure that you have the right lifestyle, do some moderate physical activity. Sometimes we use pharmaceutical agents to counteract stress, which are called as adaptogens, and social support at an individual level. So simple things like diaphragmatic breathing, progressive muscular relaxation, whatever may be the technique in whichever part of the world, including yoga, is going to help. Well, nutrients have a huge role. Simple carbs promote cortisol response. Complex carbs blunt the insulin resistance. Saturated fat blunt insulin resistance. MUFAs and PUFA improve the affinity constant for cortisol binding globulin for cortisol. And we know proteins and tryptophans make the vulnerability to psychosocial stress better. So carbs are linked to stress. We have data from Nurses Health study and westernized diet. We clearly show, and NAN study very clearly, there is an inverse correlation between fiber and CRP levels. We also know carbs trigger serotonin and tryptophan because carbs rich foods, and therefore if you have low GI foods like fruits and veggies, they can make a difference on the brain chemistry, and therefore we need to blunt that. So obviously the dietary carb recommendations need to have fiber and low GI foods and complex carbs. High fat meals stimulate low grade endotoxinemia, increase bacterial endotoxins and inflammatory antigens. High fat meals increase NF kappa beta activation and a lot of leukotriene damage, and that will lead to a lot of negativity, a lot of inflammatory activity. And that's what is known, very well derived, particularly in Asian Indians. A lot of work across the world has shown that it is very, very damaging, and therefore you need to limit our carbs. So nutrition and stress is very closely linked, and decreasing and eating the right food is very important. Supply a lot of antioxidants, fibers, drink fresh, clean, filtered water, reduce caffeine consumption, and avoid genetically modified foods. Well, the best way to break stress is regular exercise with intensity, frequency, and duration. And that's the key, and good sleep. So obviously now let's look at the last part of my talk, and you need to enter your body into a stress-free zone. And these adaptogens are nothing but novel metabolic regulators. They are full of them on the internet. And these are all nothing but phytochemicals. So clearly we know that this was a term adaptogen coined by Russian scientist Nikolai Lazarev in the late 1940s. Adaptogens are basically nothing but medicinal plants which augment resistance to stress, increase concentration, performance, and endurance during fatigue. And you see the attention duration of fatigue comes down, and these adaptogens have a lot of things. So typically the adaptogens have a property. They are non-toxic to the recipient. They are having non-specific activity, and they resurrect. You can see it in this, that in the alarm phase, tiredness, phase of resistant fatigue phase, and exhaustion phase, they try to resurrect the allostatic tree. So adaptations work by regulating homeostasis. They control the key mediators of stress response like the stress activated JNK1, transcription factor, DAF16, cortisol, nitric oxide, and they might have multiple effects like neuroprotective, anti-fatigue, and all that, but they all need good RCTs. So typically you see conventional stimulants and adaptogens. Conventional stimulants are sympathomimetics. For example, typically we'll have a coffee or a tea. They will nothing, but they will actually lower the recovery process. They will deplete your energy. They will have poor quality of arousal, and addiction potential is high, side effects are high, and they are genetically going to cause micro DNA and RNA damage. Well, adaptogens will improve recovery, won't cause energy depletion, will improve your performance and survival of stress with good arousal, no addiction potential, rare side effects, and are improving this thing. So we have several of these adaptogens. Most popular is a Chinese adaptogen called ginseng. Then of course we have green
Thank you,
tea,
Dr.
green
Shashank,
coffee,
for giving a very
garlic,
lucid lecture
carotenoids,
on
several
stress
vitamins,
management and
and
all.
obviously all these
And
adaptogens
actually, the last
are
slide is a
nothing but
wonderful slide.
natural foods consumed naturally. So if you go back to nature, go back to organic foods, eat well, sleep well, eat on time, eat slowly, eat the right food, and obviously sleep well, we can make an impact on stress. Slow down. Really enjoy life. Thank you so much for a patient hearing. So good morning, everybody. I must
the loss of a loved one, whether it be a partner or a parent, can cause a very stressful situation and cause acceleration of the blood sugars. And also that can lead to other complications. So Dr. Shashank Joshi has clearly outlined about how to manage the stressful situation and set adaptogens. So if any questions are there from the floor, you're free to ask. Dr. Shashank Joshi. Yeah, I think we'll call it. I'll now hand it over to the organizers. Thank you.
So the next session will be DPP-4 inhibitors and their continuing relevance in clinical care. So to chair this session, I will invite Dr. R.P. Rajesh and Dr. Gauri Shankar to the stage. And the speakers for this session will be Dr. Manoj Chawla and Dr. Vijay Bhaskar Reddy. Over to the chairperson to take the session forward.
So good afternoon all. As we move on to the next session, may we request Dr. Manoj Chawla to give a talk on getting the most out of gliptins in Indian patients, please. Over to you, sir. He needs no introduction. He's there with us for the past 3 days.
Thank you. Right. So we have a session which is going to be lasting an hour, 2 lectures and some panel discussion. My topic is getting the most out of gliptins in Indian patients. The disclaimer is this is an MSD supported lecture and I am contracted for the same by MSD India. So the content for the talk is going to be about looking at the gliptins in India, the current status, what have been the success factors for gliptins and the use in India, what really would be the profile of the right patient or which one may be the wrong patient for the use of gliptins, and then allow me to summarize the entire conversation with some take-home message. So we look at gliptins in India. Well, it clearly is a popular class. Many patients get a gliptin or a gliptin plus metformin combination as the first anti-diabetic medication. Gliptins form part of the regimen in a very high number of patients in India. So if we have to think back in terms of what medicines we've been using of late, well, clearly the DPP-4 metformin combination seems to have taken over from the sulfonylurea metformin combination, which would have been the drug of choice in the past. The choice of agents, when you look at what do we have in our armamentarium to treat diabetes, you have a single bigonide, which is metformin. You have 4 to 5 different sulfonylurea still available in the market, 2 to 3 different alpha glucosidase inhibitors, 4 SGLT2 inhibitors, 7 or 8 different kinds of gliptins in the market, and all this available at different price points. And the experience with gliptins has been more than 12 years. So till last year or the year before that, we were talking about a decade of gliptins in India. Now, of course, it's been more than 12 years of usage. So why really are gliptins so popular in India? I do not have to present the data on the same. It's more like us reflecting in terms of why have gliptins become so popular. A lot of philosophies behind that. Were these the drugs which continue to be the ones which seem to be extremely safe for the physician to use? Are these the drugs which have more predictable outcome? Are these the drugs which can be used across the spectrum of different age populations without being worried about possibility of side effects? And many such factors, which if I was to ask all of you here, why do you think gliptins have become popular? So there are plenty of choices with certain unique features. And of course, Indians do like choices, and why not? So till almost 2 decades back, our choice in treating diabetes was restricted to 1 or 2 sulfonylureas and metformin and insulin. But over the last decade and a half or two, the things have opened up with much more choice for us to treat our patients better. In terms of efficacy, they're generally similar to other oral anti-diabetic drugs. And importantly, the reason that gliptins have done better, or we've chosen more gliptins in India, is because of its greater efficacy. So when we first got gliptins, the efficacy data given to us from its phase 3 clinical studies was that we expect 0.6 to 0.7% reduction in HbA1c. Now, of course, every time you're given efficacy data, you should look at the baseline HbA1c. And most of these studies would have a baseline HbA1c of around 8%. So from 8%, the data said that you're going to expect about 0.7, 0.6, 0.8% reduction in HbA1c. So when these drugs were launched in India, because of the price that they came at initially, which was much lesser than the price they were being sold across the world, but from India price sensitive point of view, it seemed to be higher than the other drugs that we were using. So most of us started using these drugs as a third or a fourth add-on drug. It was expensive. They said only 0.6, 0.7% really reduction in A1C. Most of the patients who probably were at the point that they would be offered insulin and who resisted the use of insulin, we started offering them Januvia at that point in time, or sitagliptin, which was the first one available at that point. So when we started doing that, you started seeing reductions in HbA1c, which was far higher than what the clinical studies had shown. Now we understand that the reason that we are getting this better efficacy is because of ethnic differences in how you respond to DPP-4 inhibitors. And multiple papers and evidence today exist that Asians and Asian Indians respond far better to gliptins because of increased DPP-4 activity in Indians, and hence the DPP-4 inhibitors are far more efficacious in our population. The tolerability profile is another factor as to why gliptins are popular. As I said, it's one of those drugs where side effects are bare minimum. There's huge body of evidence and overall predictability. So you may think of many other choices for your patients, but you will sit back and think that if there's one group of drug that I can give to the patient, where patient doesn't have to call me back in between visits, or I shouldn't be worried about side effects, whether it is hypoglycemia, whether it is infections, whether it is weight gain, or any of those other side effects, then I know that these are the safer medications. There's no headache really in using this because you will have predictable response. So we talk about targeting maximum DPP-4 inhibition. So higher glucose levels and higher BMI will actually have higher DPP-4 activity. For higher glucose values and for patients with higher BMI, will the DPP-4 inhibition be more effective? Is there really evidence to the same? So let's see what kind of evidence do we have. So when you talk about efficacy of gliptins, there are some key determinants which decide how efficacious will a gliptin be. And it depends also on how much of the DPP-4 stays inhibited over an entire 24-hour period. Less DPP-4 inhibition would mean more or higher DPP-4 activity, which would mean that it's leading to less active GLP or GIP available in the system, and hence, of course, less effect on the beta and the alpha cells. So let's look at the residual DPP-4 activity after the use of different gliptins. Then what's seen here, I think this is the pointer, yes. So what's seen here is when you look at vildagliptin, okay, forget it, I still can't get the pointer there. So when you look at vildagliptin, the residual DPP-4 activity still seems to be about 71%, and you have more than 90% inhibition only when you're going to be using it twice a day. For teneligliptin, it's still 40%, saxagliptin 26.5%, linagliptin 15%, and the least residual DPP-4 activity after its usage once a day is for sitagliptin at 8.3%. So more than 90% DPP enzyme stays inhibited even 24 hours after the dose is what is the benefit for sitagliptin. It works intermittently. It's okay. Yeah, that part is working, not the pointer. Okay. So in terms of efficacy of gliptins, I said among the key determinants, one aspect to remember is how much of DPP-4 stays inhibited at the end of 24 hours. Clearly better evidence for sitagliptin as compared to most other gliptins. So why should this really matter? Now, this is what is happening. This is the physiology of incretin secretion. If we see this slide, in black, you have the glucose profile, and in red, you have the incretin release, which very often matches the profile of glucose activity, so that there is inhibition and there is reduction. So physiologically, incretins, the area under the curve would increase after every meal because of to maintain the glucose homeostasis. So most gliptins would inhibit DPP-4 robustly, but this happens predominantly in the first few hours after its usage. For some DPP-4 inhibitors, the DPP-4 inhibition falls after the first 10 to 12 hours, which requires a second dose to be given mandatory for you to achieve optimum DPP-4 inhibition. But what we see here in the profile is the natural physiological incretin release and glucose homeostasis. But when the DPP-4 is not optimally inhibited, it continues to deactivate GLP-1 and GIP, and you don't get any benefits of the drug to the extent that you're looking for. So increased DPP-4 activity, reduced incretin effect, and that leads to hyperglycemia and not glucose homeostasis, which was to be achieved. And this disparity is what is going to be deciding. Sorry. So DPP-4 inhibited throughout the 24 hours period will mimic physiology. Now, if that weren't to happen, this is what you would see in a person with diabetes, not sufficient incretin activity and hyperglycemia. But when you use DPP-4 inhibitors, which will give you the predominant effect, you will get again something which is mimicking the physiological incretin glucose homeostasis picture. However, when the DPP-4 is not optimally inhibited, which may happen with some of the other gliptins, and we showed there was residual DPP-4 activity with many of the gliptins that we talk about, this is the different scenario that you will see. So if I was to go back and show the profile between glucose and the incretin, the parallel release along with the same lines would be something seen with sitagliptin, and where there is not optimum DPP-4 inhibition with any of the other gliptins, you will see the difference in terms of after the initial hours, the incretin release gets hampered because of not enough DPP-4 inhibition after the first few hours of usage. Now you start looking and start comparing the efficacy of the different gliptins available. And this is with sitagliptin in head-on randomized clinical trials. So we look at the data with vildagliptin. You're seeing almost similar reduction, numerically better for sitagliptin, 1.2% as compared to 1% for vildagliptin, which is twice daily. You look at saxagliptin, you're again getting a numerically better reduction in this trial, 0.62 for sitagliptin as compared to 0.52 for saxagliptin. But you look at patients who had some amount of decompensation, and there you see better results again for sitagliptin as compared to saxagliptin, which is 1.1% reduction in A1C as compared to only 0.6. And then again in linagliptin, head-on comparison between sita and linagliptin, you see better reductions, especially in the fasting plasma glucose in this head-on trial between sita and lina. There is also evidence for gemagliptin, but we understand gemagliptin is not available anymore in India. And you again saw 0.8 and 0.77% in both these groups in a head-on comparison. So comparative effectiveness, you get similar efficacy either as monotherapy or combination therapy. Now you start seeing the data here, and you're looking at when you're using either of these gliptins as monotherapy, you're using them after metformin, and in the third scenario, you're using them after sulfonylurea and metformin. And in our clinical practice, all these three scenarios may be seen. You may use gliptin as the first monotherapy. You may use it very often in combination with metformin, or for many other patients who are already on SU-Met and require an additional drug, you will be adding a gliptin. And you start seeing the efficacy there again. So sitagliptin, again, continues to be numerically higher in terms of its efficacy as compared to any of the other gliptins, whether it's as monotherapy or post-metformin, or even post-addition of sulfonylurea and metformin. And this is important because sometimes there continues to be perception in the minds of the physicians that is a particular gliptin far more effective. Sometimes it's also a perception that when I use a particular gliptin twice a day, am I getting more efficacy than sitagliptin once a day? And the data is here for all of us to see that across the spectrum, when used as monotherapy, in combination with metformin or on top of SU metformin, you're getting better efficacy results with sitagliptin. Now, there are some predictive factors for effectiveness of this gliptin and metformin combination. Now, this is data from the COSMIC study, which was a 4-year durability study of initial combination therapy with sita and metformin in patients with type 2 diabetes in clinical practice. Now, there is clearly a difference between the responders and non-responders in this study. So you had more than 88% of the patients responding per protocol over a 4-year period, 0.8% HbA1c reduction with or without attaining the target goal of HbA1c less than 7%. Now, there were some predictive factors for response. Now, in those patients whose HbA1c at baseline was more than 8.5%, those who had a shorter duration of diabetes, no family history of diabetes, who had low HOMA beta and high HbA1c at baseline had a better response. In patients with HbA1c less than 8.5 at baseline, those who had amongst that group higher HbA1c were the better responders within that group. Now let's look at some more factors here closely. So some factors that may impact the efficacy of gliptins. Smoking affects it adversely. Weight gain while on gliptins. Okay. Fine, thank you. So smoking, weight gain while on gliptins, all of this reduce the anti-hyperglycemic effect of gliptins. Higher insulin resistance and higher levels of triglycerides also somehow reduce the 6-month HbA1c response to DPP-4 inhibitors. Higher level of serum DPP-4 requires more robust DPP-4 inhibition. So wherever you're able or ethnically you know that this is a population which has higher DPP levels, you will require a drug which is more robust in reducing the DPP-4s. And in terms of race, significantly higher DPP-4 activity observed in Asians and Indians. There is evidence to the same for both group of drugs, DPP-4 inhibitors and SGLT2 inhibitors, but not for GLP-1 receptor agonists in terms of higher efficacy in Asians and Indians. What are the means of tackling this? When patients have issues with smoking and weight gain, lifestyle measures and counseling helps. Wherever there is higher insulin resistance, you address insulin resistance through whatever means of, again, lifestyle changes and drugs which can target the insulin resistance there. And where problems exist of higher DPP-4 activity, you really need to use a robust DPP-4 inhibitor. Now, some more efficacy considerations focus on achieving target HbA1c more than HbA1c reduction. So if from 8.5, you're getting 1% HbA1c reduction, but yet most of your patients are above the target of 7%, that's not your goal. Your goal is not to improve in HbA1c and not get your patients to target. So start thinking about how many more patients are you going to be able to get to your target HbA1c. Early usage with metformin seems to be the way today for greater durability. Let's also understand that when till few years back, all of us were told that let's go stepwise, don't be very aggressive, use one drug after the other, start with metformin, build up metformin, then only move to the second drug. This is because the second drug used to be sulfonylureas. We didn't have other options till few years back, and hence the need to go stepwise, because early introduction of sulfonylureas sometimes in the past led to hypoglycemia, led to weight gain, and hence the need to go stepwise. Let's understand today you have drugs which are glucose dependent. They work in a glucose dependent manner, the gliptins. There is no increase in weight. There is hardly any chance of hypoglycemia when used in combination with metformin, and clearly data supporting durability of action if used earlier on with metformin. The role of lifestyle modification continues to be extremely important, and the high degree of beta cell failure which exists still allows the gliptins to be effective because they don't work only on the beta cells, but have a huge impact on the hyperglucagonemia in patients with type 2 diabetes by working on the alpha cells in the pancreas. So what we don't want the DPP-4 inhibitors to do, of course, is inhibit anything but DPP-4. So which is where the problems come up about whatever little side effects that you see because it's off-target actions. So let's look at the selectivity profile of different DPP-4 inhibitors. One of the ways of looking at it is looking at which DPP-4 has more than 100% selectivity for DPP-4 as compared to DPP-8 or DPP-9. And when you see that, you see sitagliptin and linagliptin falling in that category, which are extremely selective for DPP-4 over the DPP-8, DPP-9. You're also looking at more than 100-fold selectivity of DPP4 of the FAP, the fibroblast active peptides. And there again, you see that most of the gliptins, except linagliptin there, seems to be more selective for DPP4 over FAP. So selectivity in general would be highest for sitagliptin, and then moderate in other categories for all the other gliptins when you start comparing their profiles. So when you talk about the other DPP4s or DPP4-like enzymes, what really is their clinical significance? Why do we want these gliptins to be more selective for DPP4 over DPP8, DPP9, or FAP? What role do they really play in the body? So DPP8, possible role in immunity, whether it's lymphocyte activation, spermatogenesis, male fertility, cardiac microvasculature, we don't know. So these are some of the postulated means, but they may be playing a role in these mechanisms. The DPP9s, again, possible role in immunity and lymphocyte activation, some in hemodynamics, which probably may also be responsible. So when we speak about the data that we saw in the SAVOR, TIMI, and trials, which put on the entire cloud and cast a cloud on the increased risk of hospitalization for heart failure, what was the mechanism? We don't know for sure. Maybe the lack of selectivity for DPP4 and impact on DPP8, DPP9 may have been the causative factors there. And then we talk about the role of FAP. So the fibroblast activating protein, possible roles are malignant progression of tumors, wound healing, and blood clotting. So what do we do to minimize the off-target inhibition? Well, so DPP8, it's dose-dependent reduction of lymphocyte count. It may lead to skin reactions, bullous pemphigoid, and all of us have seen some of the other increase in skin rashes, skin reactions, some small boils, etc. on patients on gliptins. Be aware, when we say gliptins do not cause side effects, that's largely true, but be aware of these possible skin reactions when your patients complain of the same. Sometimes you may have to get them off of that gliptin. Sorry, I was told to increase it because they wanted to have panel discussion of only 10 minutes and to take the talk to 25 minutes, which is why I'm going slow, Chairperson. Right? I'll still finish at the earliest. Thank you. DPP9 in cardiomyocytes. DPP9 inhibition with saxagliptin reduced calcium in the cardiomyocyte, reduced cardiomyocyte contractility. We don't know, again, as I said, that's responsible for the heart failure and poor pumping of the heart because of the DPP9 activity there. Now, drug interaction with gliptins is another aspect that you need to know to differentiate between the different gliptins. So when you talk about metformin, SUs, TZDs, we know that they have some interactions, especially when it comes to use of strong CYP2CB inducers like rifampicin, gemfibrozil, etc. But let's look at the gliptin class. In sitagliptin, it's not appreciably metabolized. It's renal excretion, 80% unchanged. No clinically relevant drug interactions for sitagliptin. Vildagliptin, 69% metabolized in the liver. No clinically relevant drug interaction requiring dosing adjustment in case of renal dysfunction. Saxagliptin has hepatic metabolism, strong concern, especially when you're using drugs which are CYP3A4 inhibitors like antifungals, diltiazem, and so on. So very often you have patients where you may be using these drugs. It's not that you suddenly have a reminder popping up telling you that these drugs are going to be CYP3A4 inhibitors. Be cautious when you're using diltiazem with any of these other gliptins. If we go back and start scanning our prescriptions, we'll suddenly realize that there may be a few patients where you actually use these drugs together. And hence, it's almost impossible for all of us to remember every time which drug may interact where. But the best way, again, is to use drugs which have the least possibility of interaction with the other commonly used drugs so that it's safe for the patient and for ourselves. And linagliptin, well, minor metabolism in the liver, but majorly excreted via the hepatobiliary route. Use of alternate treatment is strongly recommended when again used with combination with P-glycoprotein, again, cytochrome 3,4 inducers. Rifampicin, I think, has the major issues if you're going to be using it for tuberculosis, of course, and your patients are on any of these gliptins. So drug interactions and hypersensitive reaction. This is one important aspect here, that don't ignore the excipients. The excipients are inert substances which are used as diluents or vehicles for a drug. Now, this is all as per the labels of the different gliptins available. You have some of the other excipients which may actually be not so healthy, let me put it that way. So presence of chemically non-inert substances in various gliptins, In sitagliptin, there's really none. In vildagliptin, it contains 47.82 milligram of anhydrous lactose. Saxagliptin contains, again, 99 milligram of lactose as monohydrate there, and linagliptin, none. So those excipients, if I go back and you start seeing, it may have adverse impact. So some of those, again, minor reactions that you may see may not be actually related to the drug, but may be related to excipients in the tablets. Gliptins in comorbidities, CKD is an important comorbidity that we all should be aware of. Again, when you look at all the different drugs, we know for metformin that you will not be initiating the drug if the GFR is less than 45. Probably you can use it in the reduced dose till GFR of 30 and have to withdraw. Similarly, with SUs, you'll be cautious as the GFR starts falling. In terms of gliptins, safety considerations, really none. You have to reduce the dose of some of the gliptins as the stage of CKD worsens. But what's important to remember is that gliptins are that one group of drugs which can be used in all stages of CKD safely. Even SGLT2 inhibitors today are approved to be used only till GFR of 30, and some of them not below a GFR of 45. But when it comes to gliptins, you can use them even on patients undergoing hemodialysis. It's just that, as I mentioned, some of the gliptins you'll have to reduce the dose, like vildagliptin, but drugs like sitagliptin also you'll have to reduce the dose, but they can be used safely in patients who are at all stages of CKD. Long-term safety outcomes in CKD, well, again, enough data showing that when you've used it in all stages of CKD, there have been no concerns. And we see this from the cardiovascular outcome trials, be it Severtimi, be it TCOS, be it Carmelina, that in the cardiovascular outcome CKD population showed or proved that these drugs could be used safely there. Gliptins in end-stage renal disease patients on hemodialysis or peritoneal dialysis. Again, this is data for sitagliptin, that in the peritoneal dialysis group, HbA1c levels were decreased more with sitagliptin as compared to any of the other gliptins which were used in patients on peritoneal dialysis. What about chronic liver disease? There's a diverse profile for the gliptins. For vildagliptin, it should not be used in patients with hepatic impairment. Teneligliptin, again, you will have to be extremely cautious. Sitagliptin indicated in patients with mild to moderate, lack of data in severe hepatic impairment. Linagliptin is the only drug which is indicated in patients with hepatic impairment. It can be used. Saxagliptin, again, indicated in patients with hepatic impairment, but of course, you'll be cautious if these patients have any amount of heart failure issues. What about with the cardiovascular safety outcome trial data? And again, all the journeys that we know through Severtimi to examine to TCOS, Carmelina and Carolina have been well published. In Severtimi, we of course saw the signs which showed increased hospitalization for heart failure for saxagliptin, which, as I said, cast the entire doubt on the group. But later on, the results that we saw, which came in through TCOS, Carmelina and Carolina, absolved gliptins, the rest of these gliptins with any connection for hospitalization increase for heart failure. And that's what is clearly seen in the data, as we see for TCOS itself, for sitagliptin and for linagliptin in the Carmelina and Carolina trials. So use in patients with history of cardiovascular disease, sitagliptin, no specific concern or warning in patients with history of CVD, you can use them safely. Linagliptin, again, no specific concern. Saxagliptin, worries about increased hospitalization for heart failure. Vildagliptin seems safe, but the problem is you're not going to ever have a dedicated cardiovascular outcome trial. It was never marketed in the US. And of course, now it's off patent, so you're not going to see any data to that effect. So it may seem safe, but because of the lack of data, you may have to be cautious, especially in patients with coexisting coronary artery disease or any kind of cardiovascular disease. Teneligliptin, no, again, cardiovascular outcome trials planned. The problem is to get optimum DPP4 inhibition by teneligliptin, you actually need to use it twice a day. But the moment you use it twice a day, there is a real concern of QTC prolongation. So when I see a teneligliptin prescription, which is twice a day, I really get worried, because this is one drug where in 40 milligram and above, it has shown clear increase in QTC prolongation. You by chance use another drug which has the same adverse event, and you are then headed for trouble. So extreme caution there with the use of teneligliptin. So let me summarize. Getting the best out of the gliptins, efficacy, ensure optimal DPP4 inhibition over 24 hours. So your choice of gliptin should be the one which has robust evidence for optimum DPP-4 activity inhibition. Focus on all these patients with lifestyle modification. It continues to be effective all throughout the journey of a person with diabetes. Safety, rule out chances of drug interactions. We are not computers that we will remember every possible drug interaction. So drugs which have least evidence of interaction should be chosen. Safety, if in doubt, if there are concerns about immunity or hemodynamic challenges, then again move to using a highly selective DPP-4 inhibitor, because that's what we want. We don't want off-target side effects. And finally, in terms of safety, rely on all the available data, whether it's cardiac or renal, to select the safe DPP-4 in patients with background comorbidities like an existing heart disease or a renal dysfunction. Thank you so much once again, and thank you to the organizers to invite me and to speak on this forum. Thank you.
Thank you, sir. Thank you, sir. That was an excellent talk. For the next talk, let me invite Dr. Vijay Bhaskar Reddy. And again, he's also a person who doesn't require much introduction. He's been here delivering repeated talks in the last 3 days. So over to you, sir. And he's going to talk about towards clinical junction DPP-4 inhibitors.
Thank you, Chairpersons. My topic for today is towards clinical junction DPP-4 inhibitors. Thank Dr. Manoj Chawla has given an exhaustive review and comprehensive review of the DPP-4 inhibitors and how to get the maximum out of DPP-4 inhibitors in the Indian population. So my topic is towards clinical junction DPP-4 inhibitors. So we know that junction is a place where everything meets. It's an intersection. So towards clinical junction is we're going to talk about the use of DPP-4 inhibitors at the junction of the various pathophysiologic processes of type 2 diabetes. So we know that we have moved from the concept of triad of pathophysiological defects to ominous octet. And now we have at least 8 defects, and the number of defects identified in the pathophysiology of type 2 diabetes are increasing. So if at all there was a drug which is intersecting at the various pathophysiologic process, it's the DPP-4 inhibitors. And that's why the topic is for today is towards clinical junction. So we'll be having an appraisal of the pathophysiological approaches to the management of type 2 diabetes using the DPP-4 inhibitors. So the content of the talk would be, I will first discuss about the glucocentric approach versus the pathophysiologic approach of type 2 diabetes management. We'll understand and approach the various pathologies in type 2 diabetes. What are the clinical implications of pathophysiologic management of type 2 diabetes? And the combinations, how choice driven by synergy and focus on DPP-4 inhibitor, how we do it. So this is the changing concepts in the approach to management of type 2 diabetes. We are moving away from a glucocentric approach versus pathophysiologic approach. We have also moved from a glucocentric approach towards a multifactorial or holistic approach. Previous management of diabetes, we are always thinking about only the numbers of the blood glucose. Now we know that if we control only the blood glucose without controlling the other risk factors like hypertension, dyslipidemia, smoking, obesity, you do not get optimum outcomes because we do not reduce the cardiovascular disease. Cardiovascular disease is the most important cause for morbidity and mortality in type 2 diabetes. So we need to have a holistic multifactorial approach. In addition to this, coming to the glucose management itself, glucocentric approach is what we followed for a long time. By meaning glucocentric approach, we have this initial stepwise approach. Initial stepwise approach where we start with diet and exercise. We wait for 3 months, 6 months, and then we start oral anti-diabetic drug monotherapy. Then we uptitrate the drug, then combination, then OAD plus basal insulin, and OAD plus multiple daily injections. You can see that in this traditional uptitration model or stepwise model, we do not reach the HbA1c target of 7% at least even once. So it takes a long time, and the time gap between each up titration from diet and exercise to one drug and two drugs, it may take up to 5 years or 10 years also. So there's a long delay. The patients are not brought to target. And we are always looking for failure. There is a glucocentric stepwise approach, looks for treat to failure approach. We'll give one drug. If it is not working, then we add the second drug. So there is a long delay and the patients are not brought to target at all. And now we know that earlier the better. We need to control the blood glucose levels early. The lower the better concept does not hold true always. So we need to do it early. So we are moving on to a pathophysiologic approach where we use a initial combination therapy with agents known to correct established pathophysiologic defects in type 2 diabetes. We use drugs with complementary mechanisms of action. So we start with diet and exercise, and especially when the HbA1c is more than 8.5%, we know that a single drug is unlikely to bring down the HbA1c to 7% from 8.5%. So there we would use 2 oral anti-diabetic drugs and quickly bring the patient to less than 7% and maintain the patient throughout less than 7%. So here we are more aggressive in the early part and bring down the patients to target and maintain them. So a pathophysiologic approach using initial combination therapy makes better sense than a stepwise glucocentric approach. So here we select anti-diabetic agents which correct the specific type 2 diabetes mellitus pathologies and have complementary mechanisms of action. So by meaning complementary mechanisms of action, we use insulin sensitizers and we add insulin secretagogues also. So type 2 diabetes focusing on the pathophysiology. So we had a triad of pathophysiologic defects. So what we understand, one is insulin resistance, where the insulin does not act well, so less glucose enters the cells, so more glucose stays in the bloodstream. On top of this, we have relative insulin deficiency. The beta cells produce less insulin than required. The beta cell stress is also there. And also we have increased hepatic glucose output. There is increased glucose production by the liver. So whatever drugs for diabetes we had for many years acted on these 3 mechanisms. So for insulin resistance, we had insulin sensitizers like metformin and glitazones. For insulin deficiency, we had insulin secretagogues. And for increased hepatic glucose output, we have metformin. So now we have identified more pathophysiologic defects. Alpha cell defect is identified. There is unchecked glucagon secretion, which is, we know that glucagon is an important counter-regulatory hormone which increases the blood glucose levels, and glucagon increases the hepatic glucose output. Incretin defect is identified. I think Dr. Manoj Chawla has clearly established the role of incretins, and we have reduced active incretin levels, and there is increased DPP4 enzyme activity, thereby degrading the endogenous incretins, which are the GLP-1 and the GIP. So there is incretin defect, you get relative insulin deficiency. And we also have increased glucose reabsorption. All the waste glucose is not going out through the urine, it's retained inside the bloodstream. There is increased SGLT2 upregulation. So this is also causing excess glucose in the bloodstream. So we have this primary causes of hyperglycemia, and we also have this increasing pathophysiologic defects which are identified. So for optimal outcomes, this may be secondary to hyperglycemia, but they also contribute to further progression of type 2 diabetes and its complications. So incretin defect, a pathology secondary to persistent hyperglycemia. Contrary to popular belief, the active levels of incretin hormones are actually not reduced in type 2 diabetes. Incretin effect is, however, reduced primarily due to a period of glucotoxicity due to GIP receptor downregulation. The correction of glucotoxicity may correct the incretin defect. This is similar to glucotoxicity affecting the beta cell response. When the blood glucose levels are very high, you will get a low C-peptide response. But once you collect the blood glucose, the C-peptide response will be better. So there is a partial improvement in the incretin defect with reduction of glucotoxicity. So these are the insulin responses to GIP. We can see when the blood glucose levels are high, the GIP response, the incretin response is poor, but at lower blood glucose levels, the incretin response is good. So a short course of insulin therapy will reverse the glucotoxicity and will improve the incretin secretion. However, you may not regain the complete incretin activity. Addressing multiple defects with various combinations. These are the commonly used first-line oral anti-diabetic drugs for diabetes. The green color columns show the effect where the drugs act. You can see the maximum pathophysiologic defects are targeted by the DPP-4 inhibitors. They target the insulin secretion. They target the reduced hepatic glucose output by reducing the glucagon. They also have mild effect on the insulin resistance. They target the alpha cell defect, incretin defect. Except for the SGLT2 action and the glucose reabsorption, they target almost all the other aspects. They have mild effect on insulin resistance. So if you combine with metformin, which has got a good effect on insulin resistance, the combination is very complementary, DPP-4 inhibitor plus metformin. So you get a complementary mechanisms of action. So DPP-4 inhibition and diabetes, is there a pathophysiologic rationale? Yes, I think we have seen this. Increased plasma DPP-4 activity is known to be associated with onset of metabolic syndrome, because increased DPP-4 activity means the incretins, the GLP-1 and GAP are degraded very fast, and thereby the incretin activity is reduced. There is associated with the onset of metabolic syndrome and subclinical atherosclerosis in newly diagnosed type 2 diabetes. DPP-4 activity has shown to have strong positive correlations with body mass index, with NAFLD, increasing HbA1c. And interestingly, it has been shown in Indians that there is significantly higher plasma DPP-4 levels in Indian diabetic population. And that is one of the reasons why we have a more robust HbA1c reduction with DPP-4 inhibition in Indian population as compared to the Western population. One of the most important predictors of the efficacy of a DPP-4 inhibitor is plasma DPP-4 concentration, which has been clearly shown by a previous speaker, Dr. Manoj Chawla. How do DPP-4 inhibitors address hyperglycemia? We have DPP-4 enzyme, which is expressed in the peripheral plasma, in the gut, in the pancreatic cells, and also it inactivates other peptides other than DPP-4. So by blocking the DPP-4 inhibition, the peripheral plasma, we prevent the inactivation of the circulating incretins. So we have a higher level of GLP-1 and GAP, and this augments the insulin secretion, and this is done in a glucose dependent fashion, and it inhibits the glucagon secretion also. In the gut, it reduces the hepatic glucose output through the portal GLP-1 receptors. In the pancreatic cells, it augments the insulin secretion, and also it inhibits the glucagon secretion, and it prevents the islet inflammation. And by inactivating of other peptides also is shown to have some action improving the islet cell function, but DPP-4, other DPP inhibition may cause side effects as shown by the previous speaker. Insulin resistance, we know it plays a central role in type 2 diabetes. So we can assess the insulin resistance by this formula of HOMA-IR. This is a homeostasis model assessment, or a quickie index, the quantitative insulin sensitivity check index. So we can have this HOMA-IR. Mostly it's used in studies, and clinical practice, we do not use this more often. So we use a fasting insulin into fasting glucose divided by 22.5. So insulin resistance may not be similarly addressed for same values of HbA1c lowering. So in this study, we can have this HbA1c reduction is similarly reduced over 2 years between sitagliptin versus glipizide. Whereas you can see the HOMA-IR, this marker of insulin resistance, is reduced only by sitagliptin but not by glipizide. So how you reduce the blood glucose may not necessarily reflect in the other aspects or like insulin resistance. Like in this study, sitagliptin and glipizide performed equal with regard to HbA1c reduction, but the reduction of insulin resistance was seen mainly with sitagliptin. This may be due to the effect on glucagon secretion, which is not seen with the use of sulfonylureas. And this is a sita plus metformin effect as compared with pioglitazone. HbA1c reduction, sita plus met was more powerful because we're using 2 oral antidiabetic drugs, whereas the insulin resistance is better reduced with pioglitazone, as shown by the HOMA-IR and the quickie index. We know that pioglitazone is an insulin sensitizer, so you get more reduction of the insulin resistance. Coming to beta cell dysfunction from insulin resistance, we're moving on to beta cell dysfunction type 2 diabetes. This is a well-known slide. At the time of diagnosis itself, the beta cell function is almost 50% lost at the time of type 2 diagnosis. So there is progressive beta cell dysfunction despite the currently available treatment. And at least initially, the beta cell dysfunction of type 2 diabetes seems more functional than structural. Thereby, if we can reverse the glucotoxicity, there can be partial improvement in the beta cell function. So we can assess the beta cell function by this formula of HOMA beta, but this is not used commonly in the clinical practice. So for similar glucose lowering, sulfonylureas and DPP-4 inhibitors affect the beta cells differently. Here we have the similar slide, HbA1c reduction at 1 year, similar between sitagliptin and glipizide, 0.67%, whereas the HOMA beta is better with use of sitagliptin, and the pro-insulin-insulin ratio, which is a marker of beta cell function, beta cell efficiency, is better with the use of sitagliptin as compared to glipizide. So gliptin and sulfonylureas, for theoretically, we think both are similar because they cause insulin secretagogues, but actually they are different in that sulfonylureas, they are not glucose dependent. They keep on acting even when the blood glucose levels are low, and they block the sulfonylurea receptor. This causes the closure of the KATP channels and calcium influx and insulin secretion. So this is not glucose dependent. So it's not a intelligent OAD. Intelligent OADs will act only when the glucose levels are high. They will not act when the glucose levels are low. Whereas the incretins, the DPP-4 inhibitors, they are intelligent OADs in that only when the glucose levels are high, they will act. And when the glucose levels are low, they don't act. Thereby, they do not cause hypoglycemia. So it's a glucose dependent fashion. The glucose, only when it goes inside, then only the GLP-1 acts. Otherwise, it does not act. So that's why, because of the glucose dependent insulin secretion, you do not have hypoglycemia with the use of incretins and DPP-4 inhibitors. So sulfonylureas and gliptins are insulin secretagogues, but both are different. So among OADs, only gliptins directly benefit the beta cells through the incretins, and these effects are not seen with sulfonylureas. So we have increased insulin synthesis and improved insulin secretion and lower beta cell stress, and all this is in a glucose dependent fashion. So GIP also reduces the insulin degradation. This is one of the other mechanisms how the DPP-4 inhibitors help. The studies have shown a decreased insulin clearance, so the insulin can act for a longer time, and thereby this is maybe one of the mechanisms how the DPP-4 inhibitors act. So studies have shown that sitagliptin efficacy may be beta cell function independent also, in that this is assessed by the HOMA beta, and this is a pro-insulin-insulin ratio. We can see that even in patients with low beta cell function, sitagliptin showed good efficacy, and even high patients with high beta cell stress, the sitagliptin efficacy was maintained. So even in advanced stages of diabetes where the beta cell function is low, the use of DPP-4 inhibitors would help because they have an additional action on glucagon system also. So the efficacy of sitagliptin was similar irrespective of the age, BMI, patient gender, and the baseline HbA1c. You get robust HbA1c reductions across the various populations. We know the concept of beta cell exhaustion, and we know that beta cells tend to fail over years. How this differently impacts gliptins and the sulfonylureas. This is a head-on comparison between sulfonylurea plus sitagliptin. The pink color one is sitagliptin plus metformin. This one is the sulfonylurea plus metformin. You can see that the initial 1 or 2 years, the efficacy is almost similar between sitagliptin and sulfonylurea. But after that, you can see that the HbA1c reductions are maintained only with the use of DPP-4 inhibitors and not with sulfonylurea. This is the concept of beta cell exhaustion and secondary drug failure. After some time, HbA1c levels, the durability is not there. Durability is seen only with gliptins. So whereas here sitagliptin monotherapy, the durability of sitagliptin has been studied over 4 years. Consistent HbA1c reduction over 4 years has been demonstrated. So after multiple drugs have failed, still the use of DPP-4 inhibitor like sitagliptin have been shown in studies. When 2 OADs are failing, you get 1% HbA1c reduction. When 3 OADs are failing, still you get reduction. So it can be used when multiple OADs are failing also. So sitagliptin also has shown further HbA1c reduction after insulin also. You can get additional 0.7% HbA1c reduction across various multinational studies. We get additional HbA1c reduction. So it's a good way. It reduces the insulin dose requirement also. Rather than keeping on increasing the insulin dose where you get weight gain and hypoglycemia, the use of sitagliptin will reduce the insulin dose and improve the HbA1c. So this is a good strategy. We should consider adding on sitagliptin instead of insulin dose up titration. You do not get additional hypoglycemia or weight gain. So we also have an insulin sparing effect of sitagliptin versus glimepiride. This also has been shown in many studies. So with use of sitagliptin, you get better insulin dose reduction. So Sita versus SU, we now talk about the concept of glycemic variability. We want to control the blood glucose levels, but we want to do this without causing much of glucose fluctuations. This is the mean amplitude of glucose excursions. This is the red color one. The curves are for sitagliptin and the blue one for the glimepiride. You can see the postprandial peaks are much more with glimepiride as compared to sitagliptin. Also, sitagliptin does not cause hypoglycemia, so you do not get much of glucose variability. So the glucose variability is lesser with the use of DPP-4 inhibitor. Addressing glucagon defect, we have identified alpha cell defect. So you need to control the glucagon, and it has to be done in a glucose dependent fashion. When we have low blood glucose, we know that glucagon is the most important counter-regulatory hormone. So when that low blood glucose levels, the glucagon secretion should not be affected, but at high blood glucose levels, the glucagon secretion should be inhibited. This is done by the use of DPP-4 inhibitor like sitagliptin. So SU plus MET does the work, but it causes hypoglycemia. Whereas if you use DPP-4 plus metformin, you do not cause hypoglycemia. So sitagliptin plus insulin also, you get better glycemic control with less hypoglycemia than insulin alone. So only gliptins address the alpha cell defect, which is not addressed by the use of hypoglycemia and other agents. So to conclude, gliptin plus metformin combination, does it satisfy the needs of pathophysiologic management of type 2 diabetes? We have seen data that it does. So it's at the clinical junction of the various pathophysiologic processes. The combination is effective in most type 2 diabetes patients. It can be used in a broad range of patients. The 3 core defects of diabetes are: one is insulin secretory defect, hepatic glucose overproduction, and insulin resistance are targeted. And the combination is durable and effective in the late stages of diabetes when multiple OADs are failing, and even as a useful add-on along with insulin treatment. So while the values of good glycemic control remains of paramount importance, the right approach is also important. So how we reduce the blood glucose levels is important, but addressing the core pathophysiologies that is responsible for hyperglycemia is also important. So if we target multiple pathophysiologies using DPP-4 inhibitor, the long-term control is good with reduction of side effects. Thank you.
Thank you, sir. I think, can I invite Dr. Manoj Chawla to the stage so we can have a discussion for next 10 minutes. And can I request someone to get an additional chair?
Okay, I'll be.
So there is a question from online. So if DPP-4 inhibitors are so glucose dependent drugs, why do we need throughout the day DPP-4 inhibition, sir? So the question is like vildagliptin once a day will do than sitagliptin, which gives a coverage of 24 hours. And now they are bringing out vildagliptin 100 mg SR. So why do we need a 24 hours DPP-4 inhibition?
So it has got multiple actions. It does not cover only for the meals. In fact, it has got other actions like it can act on the fasting glucose. It can act on the hepatic glucose output also at night when you're sleeping. So it has got additional actions. That's why you need 24-hour DPP-4.
So if I can add to that, because that was part of my presentation. So there are two different things. When you talk about a glucose dependent action of a drug, and you're talking about the DPP inhibitory capacity over 24 hours, these are completely two different things. When we speak about glucose dependent action, for the drug to have any action which is glucose dependent, the drug will need to be present in the body in terms of its ability to inhibit the DPP4 enzyme. So the fact that it is glucose dependent means that the drug acts only when there is hyperglycemia, then there is effect on the beta cells and suppression of the alpha cell. In case the sugar starts dropping down, it pulls back the effect from the beta cell and starts stimulating the alpha cell. So it's almost akin to somebody driving a car and you are doing the acceleration and brake and maintaining. So that is the glucose dependent action. In terms of why you need to have a 24-hour inhibition of the DPP4 activity, because the entire benefit of the drug is related to its DPP4 inhibitory activity. So if the drug is not going to be effective after the first 10, 12, 14 hours, or the DPP inhibitory activity will drop down, all the benefits, all the actions, including its any glucose dependent action, will just not happen. And hence the need to look at the selectivity and the inhibitory capacity. In terms of sitagliptin once daily compared to vildagliptin, so I know there are a lot of companies, the Indian companies, which have come out with once daily 100 milligram. Well, I really have to see the data, and I have my doubts about that, because there were issues when the innovators, when Novartis had its vildagliptin, they had looked at making their vildagliptin twice a day. In its earlier days of that research itself, they had seen again problems, whether it was with hepatic toxicity or QTC prolongation. I'm not very sure, but there were problems, because you should sit and wonder as to why, if it was so easy to make it 100 milligram once a day, why did Novartis have it as 50 milligram BD to begin with?
Agree with Dr. Manoj Chawla, because Novartis, the innovator company, did not come out with once a day. But now many Indian companies are coming out with once a day technology. They have put as Osmo technology. So we have to wait and see, because otherwise the innovator would have already brought it.
Dr. Rajput is here. He must have cleared it in the comments of this. So mic for Dr. Rajput, please.
Actually, innovator company has also tried to do the same, and they have come up with the proposal in the body. I have some information also, that is not important, but they were asked to answer 3 questions. Number 1, they need to address safety issue of 100 milligram, because with initial application with US FDA with 100 milligram, there is a concern for hepatotoxicity. Number 2, being an innovator company in Europe, why they are not bringing 100 milligram preparation in their parent company. So for that, they say, this is an India specific strategy. So the people does not agree. And third, if you are bringing a new product, also test it against the reference product for its efficacy. So they does not want to do any study. So for that reason only, they have come up with the proposal and then they retracted. Our Indian companies, they have agreed to do BE studies. BE study means with 100 milligram SR, they have compared the mean level of vildagliptin achieved with using 50 milligram twice a day, which they have proved with the regulators. But then the main body does not agree even for 100 milligram SR till the time you prove safety in terms of hepatotoxicity. But in our government system, there are many tiers. So if you fail at one tier, there is always a scope for applying and appealing against the initial judgment. So those who are sitting upstairs, the companies have convinced them somehow. And that's how the 100 milligram SR is now coming in our country with many companies.
But in the scientific mind, there is genuine concern about the hepatic toxicity with 100 milligram.
And that is why it's a true story. But if you now go on literature, you will find out that even in Europe, there are some studies where they have shown that the use of 2 tablets in a day, given at the same point of time, hepatotoxicity is not observed. So these are all debatable questions, but you are absolutely right. That is why there is a concern about hepatotoxicity.
True. Thank you.
There is another question, sir, with so much of CVOTs have come. So, but what are the impending indications where you will put a patient on sitagliptin than over vildagliptin or linagliptin? So this patient deserves, yes, sitagliptin. So with low chip gliptins now available. So where does sitagliptin score over other molecules?
I think wherever affordability is not an issue, I think sitagliptin is one of the well-studied gliptins. Right from the start, we have all mechanistic studies across the various populations. We have randomized control trial evidence in the TCOS trial with cardiovascular disease. We have evidence for CKD, hepatic impairment. You name anything, you will have studies on that. So wherever there is a cost is not an issue, we would always prefer the DPP-4 inhibitors, sitagliptin. So, but the other question you asked, where specifically? So a cardiovascular disease patient, we have randomized control trial evidence for safety. If you are using a gliptin, it's preferable to use a sitagliptin. Similarly, CKD also, we have, Sir has shown data even on hemodialysis patients. Only thing, we need to do a dose modification. So linagliptin you can use without any dose modification, but sitagliptin is also safe. Only thing you have to do a dose modification. Mild to moderate hepatic impairment. I think we have data across the whole spectrum. All the mechanistic studies are available. So wherever cost is not a constraint, the gliptin use preferably we can use sitagliptin because of the mechanistic studies, and it's been extensively studied with CVOT trials and randomized control trial evidence. Sir?
I think for that and many other reasons that we already showed in terms of its selectivity, its cardiac safety, its numerically better efficacy, least interaction with other drugs. So clearly amongst the gliptins, I think sitagliptin is and should be the preferred choice. Yes, of course, in a self-pay market, when you have generics available, for those where affordability is an issue, you will resort and use to any of the other gliptins. But otherwise, in terms of data science, I think sitagliptin continues to be having the best evidence for itself.
As we are running short of time, one final question to conclude, sir. Both of you can answer. What are the conditions where you are going to absolutely avoid a gliptin therapy?
So I think your one concern is going to be in patients with pancreatitis. Even though in the more recent studies, they haven't connected gliptins with pancreatitis or pancreatic cancer, it does continue to be a concern. So patients who had history of pancreatitis, it's best to avoid this group of drugs. Any patient who's had a known allergic reaction to the gliptin is another category where you'll absolutely avoid these drugs. As we showed in certain cases of advanced hepatic dysfunction, there isn't great evidence for any of the gliptins, including linagliptin. When it comes to severe hepatic dysfunction, you may still want to avoid the gliptins. Patients with history of hospitalization for heart failure, Saxan, Allo will be a question mark, but the other gliptins would be safe to use. And of course, anybody with medullary thyroid carcinoma, the entire incretin class is best avoided.
Sir, do you give a trial therapy of stopping the drug when somebody comes with allergic rhinitis or anything?
Not really with allergic rhinitis. I mean, that's too common in our country. We'll have to stop all the drug. But when you have patients who are specifically telling you about certain skin issues arising after a gliptin, it may be worthwhile to stop and see.
Reddy sir, I want to ask one question. Whether we can use this DPP-4 inhibitor along with GLP-1 analog to get the added benefit of blocking the endogenous DPP-4 activities. Is there any your
Only
ideas?
theoretical advantage is DPP-4 will also block the GIP. GIP action will be enhanced with the use of DPP-4 inhibitor on top of GLP-1 analogs. But practically, we don't use it because it does not make much meaningful difference in a clinical practice.
True. Right. So the studies have shown that there is no benefit. So don't waste the patient's effort and money on using a GLP with a DPP-4 at all, not to be used.
Thank you, sir.
So one more contraindication for DPP-4 inhibitor is pregnancy and lactation. I think that is also.
So thank you, sir. Thank you, both the speakers. We had a wonderful session. I think for a short of time, we are concluding this session and over to the organizers for the subsequent session. Thank you.
So I thank the chairpersons and the speakers for their wonderful talks and the lively discussions. So we will move on to the next session. And this session will be insulin at 100. And it will be chaired by Dr. Usha Ayagri. And the speaker will be Dr. Rajesh Rajput. who will be speaking on pleiotropic benefits of GLP-1 analogs. Agonist. Sorry.
Many thanks, Dr. Balaji, and welcome. We're in the final leg, and there we go. And we're in the final leg of the race. Please don't escape for lunch. We have a fantastic session coming up. Please do keep us company. We are grateful to Lilly and acknowledge the sponsorship and material provided by Lilly for this session. During this session, I have a wonderful set of panelists. I have Dr. Rajesh Rajput, who's going to kick us off with the pleiotropic benefits of GLP-1 receptor agonists. Then we have a tape talk from Dr. Seshank Joshi about the evolution from iletin to Humalog and beyond. And then we have a panel of super duper experts talking to us about insulin in various contexts. So please hang around and keep us company. Thank you.
Thank you, Usha. Good afternoon, ladies and gentlemen. Well, this is the last session, but not the least important session. We are discussing about DPP-4, SGLT2 inhibitor, and GLP-1 receptor agonists are another class of agent with a very bright future with the data coming up. And sooner in next 3 to 4 months, we are going to have an oral GLP-1 receptor agonist. The biggest challenge which most of us faces that it's an injectable therapy. So when probably an oral GLP-1 is going to come to the market, it is going to change the scenario how we are utilizing GLP-1 in our routine diabetes practice. It is an underutilized drug, although it has a huge benefit in terms of mechanistic aspect and the benefit which patient gains out of this therapy. This is the only therapy which has shown reduction in atherosclerotic endpoints. Even SGLT2 benefits are not driven by reduction in atherosclerotic endpoints. So probably there are differences in mechanistic aspects on benefits of CV outcome with GLP-1 receptor agonist as compared to SGLT2 inhibitor. So I am going to discuss briefly, start with a case, 66-year-old female, known case of type 2 diabetes since 15 years. Patient also has hypertension. Patient is presently receiving metformin 1.5 milligrams per day, sitagliptin 100 milligrams OD, empagliflozin. Patient is obese with a BMI of 27. As you see, eGFR is reduced, 62 ml. Patient has a blood pressure of 144/80, and she underwent coronary angiogram where diffuse 3 vessel disease is shown. So she has not suffered from atherosclerotic cardiovascular event, but she is in a high risk to suffer a future event. She has a diffuse 3 vessel disease. So this makes a case for a type 2 diabetes primary prevention cohort where an acute event has not happened, but she is at a high risk to develop an acute event. So what type of therapies we are going to use in this case, or we are going to modify the anti-diabetic agent? Although as you have seen and you have listened to the previous lectures, patient is also already on DPP-4 inhibitor, patient is already on a gliflozin, which is empagliflozin and metformin. So what necessary changes we are going to make in this patient to probably avoid future cardiovascular events? Now, first question for you is, do you think there is a concern for cardiovascular disease in this case? How many of you agrees? I think all of us agrees. There is a concern for cardiovascular disease. So if there is a concern, the next important question is, what is her future cardiovascular risk in the next 10 years? Because that is again very important. So what do you think? Her risk is less than 10%, 10 to 20, more than 20, or more than 30? Just a rough guess. Okay, so if you apply Framingham risk calculator for primary prevention, she does not suffer from any cardiovascular event. So her risk come out about, although it is not shown here, I have calculated, it comes about 17.5%, which means close to 20%. So she is at high risk for developing a coronary event or atherosclerotic cardiovascular event in future by Framingham risk score using primary prevention cohort. Now, if we see the prevalence of diabetes, we already know India is a second behind China as far as prevalence of diabetes is concerned. by 2030, we expect to have 101 million people with diabetes. And by 2050, the number is going to be 134 million. So these are staggering number of people who are suffering from diabetes. And we are not bothered with the numbers, but what we are bothered, majority of them are not getting into control with the current therapies. And the result is they are going to have increased prevalence of micro and macrovascular complications. Also, we have to understand a very important fact. We as Indians, we as South Asian populations, we are different from our Caucasian counterparts. We have different cutoff to define overweight and obesity. Some of you who were present yesterday, we have discussed that between 23 to 25, we define overweight, and more than 25, we define obesity, in contrast to Caucasian counterparts, where it is 30. So we are different. We have more visceral adipose tissue, and it is visceral adipose tissue which is more dangerous. Even at a so-called same apparently normal BMI, we have visceral adiposity which is present in all of us, and this is visceral adipose tissue which is metabolically more active, more harmful. We also have higher onset of diabetes, but the onset is happening 1 decade earlier as compared to Caucasian counterpart, which means we have to live a pretty long period of life with diabetes, which means we are predisposed to micro and macrovascular complications. Not only that, degree of control is also worse in our population. Also, at the same degree of insulin resistance, Indians and South Asians have low beta cell secretory capacity as compared to Caucasian counterpart. And lastly, the response to the drugs might be different in our country or in our population as compared to Western population. And we have a different lipid profile. Even at a same low LDL, we have more dense particles and we are developing coronary artery disease. So we have lots of differences as compared to our South Asian, Caucasian counterparts. So we have to treat our population accordingly. Now coming to asymptomatic coronary artery disease in patients of type 2, and this is Q risk calculator. This is another calculator which is more predictive of future coronary event in populations like our population. Now here, as you see clearly, I will not go into the details of this slide because of the time allotted to me, but as you see clearly, depending on duration of diabetes, as duration of diabetes increases, the 10-year Q risk 3 score increases proportionately. And the relative risk in compared to healthy individual is significantly high in patients with poor control and long duration of diabetes. So this brings me to an important concept, what we have learned from STENO2 trial, that when it comes to the proper management of type 2 diabetes, it is not only glucose. Diabetes is not a disease of glucose. Diabetes is a metabolic disease. There is a common mother, common soil hypothesis, which is responsible for causing number of metabolic problems in a patient of diabetes, which include hypertension, dyslipidemia, obesity, and so on. So when it comes to proper management of patients of type 2 diabetes, it is multifactorial approach. You have to do lifestyle modification, you have to do blood pressure control, you have to control lipids apart from glucose. And if you see again the data, the benefit of multifactorial control, when you treat 200 patients for 5 years, if you reduce your systolic blood pressure and bring it into control, there is a significant better advantage in future prevention of cardiovascular event as shown in the cartoon, followed by beneficial effect when you control LDL into the target. As far as coronary artery disease is concerned, glucose comes to the end. But then we must remember these data were created and shown to us in an era when we does not have therapies like GLP-1 receptor agonist, like SGLT2 inhibitor, or combination of GLP-1 receptor agonist and SGLT2 inhibitor. So these data are extrapolated from our old studies, which have clearly established the superiority of blood pressure, lipid control over glucose. But now CVOT trials showing superiority with the new agents like GLP-1 receptor agonist and SGLT2 in next 10 years of time, when we have lots of data collection, probably this figure may change and bringing again into forefront the importance of aggressive glucose control in patients of diabetes. If we see the effect of intensive versus standard glucose control, again, these were the studies done with older conventional glucose lowering agent, where it has been clearly established that you have established cardiovascular disease, intensive glucose control is not that rewarding. You have to be careful. You have not to target HbA1c of less than 7% in a patient who is having long-standing diabetes, already has suffered from myocardial infarction or stroke, because in those patients, reducing HbA1c aggressively to less than 7% might prove counterproductive. But I have my doubts because these are all done in era when the newer class of agents are not available. So probably in next 5 to 10 years of time, we might have again a new tables, new forest plot graphs where the glucose control with newer agents might provide some new benefits. So let's see evolution of type 2 diabetes. I've shared with you the old data, and we have seen that era, and some of you also have seen that era when we have only metformin available for treatment of diabetes. And then we have only one sulfonylurea, which is glibenclamide, available to treatment of diabetes. We have only insulin therapies in form of NPH and regulars. But then as era evolved, as research goes on, comes the era when initially thiazolidinedione and later on DPP-4 inhibitor comes into picture. But in this era, again, we only focused on HbA1c reduction. But what this era has told us that with the study done with rosiglitazone, Steve Nissen data, that all newer anti-diabetic agents should prove their safety by doing CV outcome trials. And that brings a new era where we have started finding out superiority of anti-diabetic agent as far as cardiovascular events are concerned. And this benefit is seen even beyond glucose control. So now we are in an era where we have started talking about 3-point MACE reduction, reduction in hospitalization for heart failure, reduction in progression for CKDs, and largely two groups of drugs are responsible for this: GLP-1 receptor agonist and SGLT2 inhibitor. So I am going to discuss with you GLP-1 receptor agonist, which are going to target, apart from glucose reduction, number of other benefits, which include beneficial effects on blood pressure, inflammation, weight, oxidative stress, benefit as far as reduction in progression of renal endpoints are concerned. If we see ADA standard of care for diabetes, again, I am not going to repeat. This slide is shown by probably all the speakers, that depending on risk profile, we are going to choose one of these class of agents along with metformin. And in fact, European Society of Cardiology have gone a step ahead. They have said, if you have ASCVD or CKD in a drug-naive patient, you can use GLP-1 or SGLT2 inhibitor even before metformin. So now we are having data where these class of agents are shown to be effective. Coming to GLP-1 receptor agonist, which is my topic, which I am going to discuss in brief. Now this slide summarizes with you the beneficial effects of GLP-1 receptor agonist. As you have learned in previous session, GLP-1 receptor agonist belongs to incretin class of agents. They causes glucose-dependent insulin secretion. They causes suppression of glucagon. Their effect is hypoglycemia independent. In fact, in monotherapy, that does not cause hypoglycemia, and they have number of other benefits in terms of, if we see at level of brain, that decreases your appetite, provide neuroprotection, decreases stroke. GLP-1 is the only class of agent, as I will share with you CV outcome trials, which have shown reduction in non-fatal stroke. With no other class of agent, reduction in non-fatal stroke has been observed. At the level of myocardium, beneficial protective effect on myocardium is observed. Nowadays, they have shown to have beneficial effect even in NASH patients and number of other benefits. So these is lots of benefits seen with this class of agent. So the first pertinent question is, when I am going to choose a GLP-1 receptor agonist, what are the considerations? we should look for presence or absence of ASCVD. We should also look for CKD. Weight, if patient is concerned about weight, he's obese. This is a wonderful class of agent, will result in weight loss. Glucose lowering effect, there is no doubt. As compared to SGLT2 inhibitor, as compared to DPP4, they are more potent as far as HbA1c reduction is concerned. Hypoglycemia, minimal risk because of inherent mechanism of action, and definitely there are some precautions which we have already discussed in last session. Now, how many GLP-1 receptor agonists are available in this country? I do not know whether you know or not. There is a classification. We can classify GLP-1 based on short-acting one, which needs to be given twice a day, intermediate-acting one, which needs to be given once a day, and long-acting one, which needs to be given once a week. And as I have told you, this classification is expanding, and soon we are going to have an oral GLP-1 receptor agonist available to us, which needs to be given once a day. There is also another way to classify based on source of origin. There can be an exendin-based GLP-1 molecule. Exendin-based GLP-1 molecules are derived from Gila monster. It's a venom which is present in this lizard, and it has got 53% homology with human GLP-1. But then this GLP-1 is resistant to degradation by DPP4 enzyme. So it has a long half-life. And non-exendin or human GLP-1 based molecules. So we have two exendin based molecules which are exenatide and lixisenatide. Rest all which are liraglutide, dula, albiglutide, semaglutide, they are on human GLP-1 based backbone molecules. Out of all these GLP-1 molecules, nowadays presently liraglutide is available to us, which we are using once a day in our country. And dulaglutide is available to us, which we are using once a week molecule. Semaglutide once a week has not come to India. Oral semaglutide probably will be coming in next few months to India. So these are all GLP-1 which are available in our country. If we look at efficacy in terms of glucose reducing potency of various GLP-1 receptor agonists, as you see across the chart, their efficacy varies from 0.9 to 1.5% depending on the baseline glucose profile at which they are used. Now, a very important question, how effective they are in Asian population. Now, this is a study which is published in Diabetes, Obesity and Metabolism. And as has been discussed regarding DPP4 and another class of agent, if you see this forest plot graph, clearly in Asians, the response to GLP-1 is much, much higher as compared to Caucasian counterparts. Another important benefit of GLP-1 receptor agonist molecule is effect on weight. Again, across the class, the response may vary from one drug to other, but across the class, on an average, 3 to 5 kgs of loss of body weight is observed in various clinical trials. But in real world, when you talk various, including me, in real world, even we have observed weight loss of 8 to 10 kgs in a given patient. But on an average, 3 to 5 kgs of loss of body weight is observed. And because of this property, one of the GLP-1 receptor agonist in a dose of 3 milligram is approved as an anti-obesity agent in United States of America. So these are some of the another benefits. Coming whether GLP-1 receptor agonist, as they are beneficial in Asians, an important question is whether they are effective in those individuals who are not having obesity or who are not having overweight. Can these drugs can provide similar efficacy as far as reduction of HbA1c and glucose levels are concerned? Now, this is another important study where it has been shown that even in people who are having normal BMI, same degree of HbA1c reduction is observed. So the effect on glucose is not dependent on your baseline body weight at which the treatment is started. If we see the effect of reduction on fasting plasma glucose, again, same degree of effect on reduction of glucose is observed. So we should not be driven by the fact that we are only going to use GLP-1 receptor agonist in those who are obese. Definitely they are preferred. But in those who are in a normal BMI, even in them, the effect on HbA1c, the effect on fasting plasma glucose, and the number of patients who are achieving a target HbA1c of less than 7% is observed even with GLP-1 receptor agonist. Lastly, coming to cardiovascular outcome trials, I'm not going to discuss them in detail. As you see, with all GLP-1 receptor agonists, there are cardiovascular outcome trials. But what I am going to discuss the case which I have shown you. Patient is having 3 vessel disease, but has not suffered from any cardiovascular event, which means he's a primary risk patient. Now, what are the studies which has been done in such type of patients? Out of all GLP-1, and you should focus on type of patients or pre-existing. You should focus on patients with pre-existing cardiovascular disease. It is only with dulaglutide Rewind trial where 70% of the enrolled patients were having type 2 diabetes and risk factors more for future cardiovascular event. And what this trial has shown us, that there is a superiority in 3-point MACE reduction, which is largely driven by reduction in non-fatal stroke. And there is also benefit in renal endpoints. If you see the meta-analysis of CV outcome trials, clearly shows there is benefit in 3-point MACE. Similarly, in kidney outcomes, in Rewind trial and with other GLP-1 receptor agonists, there is a beneficial effect on progression of CKD in patients of diabetes. Lastly, there are 2 important side effects, nausea and vomiting, which are limiting effects in some patients, but largely patient tolerate them well. You start with a lower dose, gradually built upon the dose, and patient will start tolerating this class of agent. In fact, in real world practice, we have observed those patients who develop some degree of nausea and vomiting, they respond much better in contrast to those who are not having any side effects like nausea and vomiting. This is what we have to observe with longer acting GLP-1 like dulaglutide, which is given once a week. The chances to develop nausea and vomiting is much less as compared to GLP-1, which needs to be given twice a day or once a day. So the longer one were having a low incidence of GI side effect. Risk of hypoglycemia is minimal, and this is comparative chart of various GLP-1 which are approved or available in India. All approved ones are not available in India, as has been shown in the slide, but definitely we are preferentially using 2 GLP-1, liraglutide, which needs to be given once a day, dulaglutide, Trulicity, which we are using once a week. So friends, to conclude with, GLP-1 receptor agonist again is a next wonderful class of agent, which apart from reducing your fasting plasma glucose, postprandial HbA1c, has been shown to be beneficial in reducing 3-point MACE, reducing atherosclerotic endpoints, reducing your future events of progression of kidney disease. They provide weight loss. So based on the beneficial effects of GLP-1 receptor agonist, so future probably lies with a newer class of anti-diabetic agents. Thank you very much.
Thank you very much, Dr. Rajput. We now have Dr. Shashank Joshi, who has sent us a tape talk. He is available online. Dr. Joshi, can you hear me?
Yeah, I'm loud and clear, but you can play the recording.
Unmute Dr. Joshi. I can see him, but I can't hear him.
Can you hear me now?
IT team, please help me.
Can you hear me now? You can play my video.
We can't hear you yet. They're just working on it. We can see you. We can't hear you yet. Now, Dr. Joshi, we have your recorded talk. So we're going to play the talk, and then we're going to come back to you for the panel with all of the rest of our panelists, if that's okay. Professor Joshi, they're starting playing your talk. Is that okay?
Yeah, absolutely okay. Please go ahead. Am I audible? Go ahead.
Right, let's play the talk, please. And in the meantime, please sort out the AV issues because we really need Professor Joshi for our panel. Thank you.
glucose and ketones. And the first patient in the US to receive treatment was Jim Havens in May 1922. In February 1922, 6 other diabetics were given the extracts with the same positive results. And that time they called that extract iletin. And it was not until April 1922 that they finally gave the name insulin. So actually iletin is the first extract which was there. And clearly post-insulin discovery, the data is there to see. This is increasing life expectancy in people attending the Boston George Barker's Clinic between 1897 and 1945, analyzed by the Metropolitan Life Insurance Company. And clearly the data is for everybody to see. Obviously, Eli Lilly took a lead in spearheading insulin availability then, way back. And Colonel Eli Lilly established a small laboratory that time in Indianapolis. And the intent was to provide medicines based on quality, precise compounding, and honest labeling. And this was way back in May 10, 1876. It was in August 1922 that Lilly shipped the first commercial insulin. And in 1923, Banting and Best won the Nobel Prize of Medicine. And Banting shared the award with Best, while MacLeod shared the award with Collins. In the May of 1922, an agreement was made between the governors of University of Toronto and Eli Lilly, the company, to mass produce insulin. And that is how, in the finishing line, Lilly made a big role, because then they commercialized iletin, which was the first international patient. Obviously, this was the first full-scale production. The first international patients were treated with insulin manufactured from Nordisk in insulin laboratorium. And by the end of 1923, Eli Lilly had shipped 600 million of units and benefited millions of patients. 1925, around 217 million units of insulin were distributed. 13 million were exported outside the US. So this is the story of insulin discovery. Obviously, then came another era. Almost, 80 years or 60 years after the discovery of insulin, the rDNA technology became available. Again, Eli Lilly took the lead step in genetically engineering human insulin in 1982, and that started the era of modern insulin therapy. And this is something that people started moving to human insulin compared to the original animal insulin of bovine and porcine. So obviously, unfortunately, patients were rather pushed beyond to human insulin following the switch. There were increased reports of hypoglycemia, and some people were asked to go back to a pig insulin, but it's a small minority who aren't on human insulin today. The great thing about human insulin wasn't that it was better than animal insulin, but we had an infinite supply, and we no longer were reliant on pigs and cats. So obviously, that was the story. So the arrival of the next big thing in insulin therapy was probably the arrival of the analogs. The first to market in 1995 was the short-acting insulin Lispro by Lilly, followed by Novo Nordisk Aspart, and then of course Glargine by Sanofi and Detimir by Novo. So those who are the next gen insulins or the analog insulins. So obviously, if you look at insulin development from its discovery to iletin to the analogs, you see that the whole story is very reflective and very, very correct. And today we have insulin for fasting, postprandial, or both, which helps to manage fasting glucose with basal analogs like a biosimilar of Glargine or Glargine, Detimar or Regulec. We have, of course, premixed products like NPH and regular 70-30, Lispro 50-50, Lispro 25-75, Aspart 70-50. And we have rapid-acting insulins like Lispro, Lispro 200, Aspart, fast-acting Aspart, new lysine, and regular insulin and NPH insulin. So obviously, this is where the insulin story starts and expanded. But not only it was insulin which was innovated, the insulin delivery systems also got innovated. Initially, there were vials and syringes, then came the pens, then came the jet injectors, then came the inhalers, then came the insulin pumps and the continuous subcutaneous insulin delivery systems, patch pumps, and of course, now we know we have the artificial pancreas. So obviously, in my short little presentation, all I want to say is that since 1921, and we are in 2021 now, discovery of insulin has saved and improved countless lives throughout this last century. With development of precisely engineered insulin analogs, which are now more physiological, have a lesser hypoglycemia and lesser weight gain, improve glucose control, reduce and delay complications, insulin is still the cornerstone of therapy in diabetes. Of course, we'll get newer and newer insulins like the U100, the junior push pens, and so many other innovations. And in the coming century, which will unfold, newer innovations like glucose sensing insulin, artificial islets will lead the way forward. how we live people with living with diabetes. I thank Dr. Krishna and his whole team for allowing me to speak in this meeting, and thank Lily for sponsoring this symposium. Thank you so much. So this was the Lily's 100 years of insulin, which had been out there. Thank you for your attention.
Thank you very much, Professor Joshi. So as I said that at the beginning of this session, we had Dr. Rajesh Rajput talking to us about GLP-1 receptor analogs, and we've just seen Professor Joshi take us through the 100-year journey of insulin discovery and development. To take us forward, can I please first ask Dr. Rajesh, because we haven't had Q&A for Dr. Rajesh session either, and also Dr. Chawla and Dr. Vijay Bhaskar Reddy to join me on the dais. And we have Professor Shashank Joshi. Yes, I can see him online.
Am I audible?
Can you please just mic check Professor Joshi to see if we can hear him?
Am I audible? Am I audible? Am I audible?
Yes, now you are. Thank you very much.
Okay.
Right. Could I just make a humble request of all of the audience? Can I just ask all of you to move forward, because we are going to do a panel and a Q&A, and I'd love it if those of you who've had the endurance to see us through to the very last session could please come forward and see us home. If it's not too much of an inconvenience, can I ask all of you to join us at the front? Thank you. That's so very kind of you. Right. Professor Joshi, you've taken us through the 100-year journey of the discovery of insulin. I guess, see, we started off with crude pancreatic extracts. We went on to animal insulins. Now we have not just human, but analog insulins in their first, second, third generations, rapid acting, super rapid acting, ultra fast insulins. How do you see this in terms of its relevance? I guess is not much of a question, but in our country like India, where resources, supply, cost, all of these remain challenges, where do you think we are in terms of distribution and equity for 100 years of insulin?
So that's a very good question, and I think it's a socio-political question more than a medical question. Am I audible?
Yes, you are. Well, you're the best person to comment on the bigger picture.
So I
Surely.
will give you that answer. So I think we need insulin for all. And I think the biggest challenge for insulin today is not really its cost or its innovation or its analogization. So I think the biggest challenge of insulin today are a mindset of physicians and people at large. I think we are delaying and deferring insulin inadvertently or purposefully because of some myths and fears. So I feel the biggest barrier for insulinization, universal insulinization and equitable insulinization is inertia. Whether it's clinical inertia, physician inertia, people living with diabetes, their inertia. So first is that we need to break that myth of inertia, and we need to overcome that. Remember, if 2 or 3 agents cannot get your A1C down to around 7 in a non-pregnant adult, or maybe 6.5 to 7.5, it's a moving A1C now, and that's a time in range which you're looking for. It's time to offer insulin in type 2 diabetics. In type 1 diabetes, gestational diabetes, or in secondary diabetes, it's a no-brainer that you need to give insulin on top. And I think the innovation, the analogization of insulin, like insulins like Humalog, they have got on table insulin which is there, which needs to be given. The issue which you asked is it affordable? Is it accessible? Does it have a cold chain maintenance in remote access areas? And to that, I think the answer is yes. To a large degree, I don't see with a vigilant media 24/7 all over, I don't see people where they are reported that they have lost their lives because of lack of insulin. Maybe 50 years back they did. Today, I don't see that happening. Even if you go to the remotest government place or public health system, you will still get insulin there. So I think that to a great extent has been circumvented. In African countries and South American countries, the story may not be as good. But I agree that we still need to focus on universal insulin access, affordable access, and continuous access. And their human insulin is still very much available. It's not that we don't have human insulin.
The analogs offer two advantages, which myself and my other speaker, Dr. Rajput, has very nicely illustrated. He talked on the new generation GLP-1 analogs. Now you need to understand two things, that the GLP-1 analogs and SGLT2 inhibitors are actually becoming a rate limiting step for easy insulinization because they have got a wealth of data. But time and again, you will get a patient with myocardial infarction. Time and again, you will get a patient with a diabetic foot infection, a diabetes for surgery, where you will need to use insulin. So I think this insulin myths need to be demystified. Even after 100 years, we still have hesitancy of insulin. We are in COVID times and we are seeing vaccine hesitancy. But after 100 years, I see still insulin hesitancy. And this insulin hesitancy is the inertia. And that needs to be circumvented. And I totally buy a point that we need to make it equitable. We need to make it affordable and accessible to one and all. And I also feel that this is not an unrealistic target today. Because I think the cost of even a modern day insulin analog is far less than what an individual needs to spend on treatment of complications. If you want to give dialysis or do an angioplasty or do a bypass surgery, it is far more expensive rather than using a affordable analog. So that's my take on it. I think I'll stop here. But I like your question. It was not an easy question to answer. It put me into a spot. I'm also the IDF Southeast Asia chair. So I think IDF is committed for universal insulin access and it is committed for affordable insulin. And if analogs cannot be afforded, at least human insulin is mandatory because we are gone away from the era of bovine and porcine insulin.
Thank you for humoring me, because when I have an expert of your caliber available on the panel, along with the rest of the experts that I have, I can't really just ask the bog standard easy questions and then get away with it. So I've got to up my game as well, I think. So you've made an excellent point. Even with all the medications, all the OADs, all the advances in non-insulin therapies that are available now, insulin still remains relevant, not just relevant, but the mainstay of treatment in certain situations and as diabetes progresses. So when we think in terms of insulinization, I'm going to put this question both to Dr. Rajesh Rajput and to Dr. Chawla. Practical tips, how do we initiate insulin? In a situation like India, would you go, we are always taught start with basals, fix the fasting first, but then the RSSDA guidelines say go for a mixed insulin. I'm going to put an open question to both of you. What's your wealth of experience? Which way would you steer us?
So I think I'll take some part of the question and then let Dr. Rajesh answer. So I'm going to add to what Shashank said in terms of the inertia part. So, we keep talking about that inertia as an issue and that needs to change. I think one of the means and ways towards that is talking to the patient about the natural progression of the disease.
So I have a specific question. Sorry to interrupt, but I do have a specific question for the
on
panel
that?
on
Okay.
inertia.
On
I
inertia
really want
as
your
well.
expert inputs on that
Fine.
as
So,
well. Yes.
We'll wait for that. So in terms of initiating insulin therapy for patients, yes, largely most of the associations have moved on to recommend the need for starting with basal insulin, targeting the fasting first. But as you said, RSSDI, and it's not only RSSDI, there are many other Asian associations which still have premix insulin as an option to initiate. So RSSDI says basal or premix, you choose. Now premix still continues to be absolutely relevant in the Indian population or the Asian population because of the high glycemic load and the high carb diet that we've seen. In fact, Shashank's START study itself has shown that when we think about the high carbohydrate intake, it is not restricted to just south of India as may have been thought, but this is a phenomenon all across India that there is high carbohydrate diet, and hence the option for using premix insulins to initiate itself. Now, there may be various means of going about it. You start seeing what is the difference between the fasting and a post-meal sugar. And if that difference is higher, then clearly the choice tends to be more for using a premix insulin in the Indian setting. To initiate, well, there are different ways that you go about by initiating, and I'll let Dr. Rajesh help us with that.
Thank you, Manoj. Actually, when we are talking how to initiate insulin therapy.
Dr. Rajesh, many apologies to interrupt, but I think we're a little, yes, we'd have a bit more clarity.
So
Yes.
this is actually a question which always comes to the mind of the beginners who are starting their career after pursuing graduation or post-graduation in field of diabetology. And I still remember my days many years back when we also used to find out the simple answer to this question. So first of all, this is not a simple question and there is no simple answer to it. When you are going to choose an insulin for a patient of diabetes, which means patient has already exhausted 2 or 3 anti-diabetic agents, you have to look at glucose profile of the patient, fasting, postprandial and HbA1c. And what is your target? Whether you are preferentially targeting initially fasting, whether your target is in some of the disease conditions like GDM and others, whether your target is only postprandial glucose, or you are targeting both fasting and postprandial. Also an important point which Manoj has highlighted, what is difference between fasting and postprandial? Is the difference between fasting and postprandial is 60 to 80 or it is more than 100? That's how actually we should take into the call. It is good to read guidelines, but guidelines may not apply to a particular patient. So if your primary agenda is to control fixed fasting first and then talk about postprandial later on, if HbA1c is not coming into the target, then basal insulinization is a wonderful option, where with single injection, you are making patient convenient to initiate insulin therapy. But always remember, if your total basal insulin dose is more than 0.5 units, if patient is still not coming into the target with use of basal insulin therapy, if patient is developing postprandial hyperglycemia or have a meal pattern, then basal insulin may not suffice in all such patients. And here lies the role where there is an increasing guidance and documents that even a single injection of pre-mix insulin before one of the major meals is a very good option in Indian Asian patients who are predominantly carb eaters. So there are different ways by which we can initiate insulin therapy, but then an important message is that we should not be comfortable or become complacent after starting or initiating insulin therapy. There are 3 steps. You have to titrate and you have to intensify the insulin therapy. The conventional teaching, which are given in the guidelines, is a very conservative approach, because when we become MBBS, we have taken a Hippocratic oath. Do not do harm to your patients. So the basic principles which are given in the guidelines are that patient should not develop hypoglycemia, should develop confidence with insulin therapy. So basically you have to gradually up titrate the dose, intensify the dose and keep on. And for all this, we need patient education. So all these are some of the points which all of us have learned during our career, as we have treated thousands and lakhs of patients, and you are also going to learn it. But as Shashank has pointed out, that it is, and to me also, I always say at various platforms, it is physician inertia to initiate insulin therapy more important than patient inertia. So first we have to make ourselves convinced, make ourselves educated about various insulin initiation strategies, and then obviously you are going to see a success in your practice when it is going to use insulin therapy.
I'll just quickly add to the means of doing it. You have, in terms of making it clear, so you could use any of the strategies, be it 0.1 to 0.2 unit per kilogram body weight, or starting with 10 units in terms of basal insulin. If you're starting pre-mixes, you may want to start even with a lower dose in some patients with 6 to 8 units per meal, and then up titrate because of the bolus component there, and to avoid hypoglycemia. So multiple different simple, easy to start and easy to titrate strategies available.
So we've heard from our experts. We have choices depending on the SMBG profile. You can either start as a basal or you can start as a premix, and this is individualized to the patient. You can start at a fixed low dose and titrate, or you can start on a weight-based strategy or on a premix at a low dose. But as Dr. Rajput has said, it is not just starting, but there is the next step of titrating and then intensifying. So thank you very much. Now, we've heard during this that there is this inertia. I'm going to ask you, Dr. Vijay, what is the physician factors for inertia? And then I'm going to go to is Dr. Joshi still there? Yes, okay. I'm going to go to Dr. Joshi because I think the patients also might have some reservations, and I'm going to ask Dr. Joshi to address the patient factors. So can I come to you first for the physician factors, Dr. Vijay?
Yes, madam. Physician factors, one is, I think, in a general practitioner's point of view, the focus on diabetes and insulin education, the medical curriculum is a bit less. So the doctors are not confident enough, especially when it comes to insulinization. And second is, in a busy outpatient clinic, it becomes difficult for you to educate and counsel the patients regarding the insulin treatment. And if so many patients are waiting, we don't give enough time to explain the benefits and we try to quickly push them off. I think in this setting, a diabetes educator or a dietitian who is trained in diabetes education will be able to help us and guide us towards the insulinization. And insulin initiation is not a single step approach or a single visit approach. Sometimes you have to prime the patients, and the next visit maybe you will have to go for the injection. So it does not be that at the same time you need to educate the patient. So we need to have some time to educate our patients, and we can use the help of paramedical personnel like dietitian or diabetes educator. And it's not a single time affair. We can educate our patients this time. We can explain the benefits. And another important thing is we should not explain that insulin is like a punishment to our patients, because traditionally we use injections as a punishment. The parents will say, I'll take you to the doctor, he'll give you an injection. So that attitude has to be overcome, and we need to explain that this is a well-established treatment. And nowadays we can also explain that the injection devices are much painless and they're much more comfortable than in 100 years back, and over time we have much improved.
So from the physician side, I guess education, knowledge, and resources, both in terms of time and maybe extra personnel. But what about the patients, Dr. Joshi? How can we actually persuade them that with this, everything else being available, how can I tell my patient, this is still the single best thing for you? We must do this now and not 5 years later. How do I overcome?
Am I audible?
Yes, yes, yes.
Yeah, so I think it's not easy to convince the patients, because patients have very peculiar myths and a lot of misconceptions about insulin. I still remember one patient telling me that, doctor, do anything but don't give me insulin. Because I said, why? So the patient answered me that because, when my grandfather was about to die, he had a stroke, and then in the hospital, he was there for 5 days and he was given insulin and then he died. Now the stroke and diabetes had nothing to do with insulin. But the perception which stuck in the mind of this patient was that this patient died and got a stroke because of insulin. It's a very wrong perception, but it stayed and has scarred the mind. This is something fearful. So my strategy is very simple. After 100 years, I tell them that the most natural treatment, because our patients love natural remedies. You give them any jadi booty, 100 times the cost of insulin, and say that this will make you go away insulin, they'll immediately take it. So I say the most natural substance our body makes, which is more than 100 years old, is insulin. So insulin is made when our portal vein has insulin. So insulin is the most natural treatment for diabetes, number one. Number two, insulin is the longest studied anti-diabetic drug on planet Earth. 100 years of evidence. I don't think there is any other drug in diabetes medicine today which is 100 years old with pharmacovigilance and all reports. Number three, unfortunately, the insulin is the most misperceived drug. It has maximum myth surrounding it with all types of things, and people boasting that they have tree barks which will cause oral insulin. Insulin is a peptide which gets degraded by hydrochloric acid. We had some inhaled forms which never succeeded, and insulin has to be injected. So that myth has to be broken, that there is nothing like oral insulin till it becomes available, and it has to be given as an injection. And the injectable insulin is effective, safe, and not only will have any, and the last thing about insulin is insulin has no upper dose limit. All tablets have upper dose limits. Insulin is an anabolic hormone, it improves appetite. All tablets will cause nausea, vomiting, all types of side effects. Insulin has no side effect except extension of its original action, which is hypoglycemia, which is predictable. And with the modern devices, we can actually predict the time action profile and insulin and its action. So insulin actually is a very simple drug to use in diabetes. If you are able to explain the patient these simple things and spend some time, and then the last thing is that the pen or the new modern age innovations, like say you use a Humalog quick pen because it's a Humalog symposium, the pain because of these ultra fine needles which are used is less painful than a mosquito bite. I ask all my patients, are you bitten by a mosquito bite? Yes. I said, this pen is less painful than a mosquito bite. It's easy to carry. You can use it anywhere. You can go anywhere. The last thing people think is that once I get on insulin, I'll be dependent on other people. See, people want to be self-reliant. People do not want to be dependent on others. So I think in a holistic perspective, if you look at it, if you spend time telling the patient the value proposition of insulin, the safety and efficacy of insulin, the ease of use of insulin, and the painless things and the self-reliability on insulin, most people accept insulin. In fact, they want insulin. But
So now
that needs time. And unfortunately, in our busy practices, as Dr. Vijay also said, we don't have time.
Yeah.
And sometimes we need to use educators, communicators, dietitians, educators, and whoever it is. But I think if you spend adequate time, I think we can overcome patient inertia very well.
So I was going to ask this question later, but since you've brought up the topic, I think now is the right time. See, you've mentioned two things. One, that insulin has no upper dose, but equally we know that there are lots of people who, especially our pediatric population or our slim type 1s, who need very small increments of insulin. And you also mentioned the devices. So we now have a plethora of devices available in the market that can inject from anything from 0.5 to 80 units. Could you just give us a quick run through? You said ease of injection with our devices.
So, you know, you have these quick pens, you have these U100s, you have these U200s. So you have actually a lot of devices in the market today where, you know, and you can, and the way they are handled, even a small child can handle it. You have a junior device. So, you know, we have all these devices from
So that's
children
the one
to
that
adults.
gives the 0.5 unit increments, the junior
Absolutely.
device. Yeah.
Absolutely.
Okay.
So we have all types of devices. So there's a lot of flexibility, ease of use, even for a child. See, basically, I call these devices as empowerment tools. They empower the patient to be self-independent. We don't call them patients anymore. We call them people living with diabetes. These are very good empowerment tools. They're very easy to use. They're very easy to dose. Also, you know, the clicks are in such a way that you don't overdose. Many of them have automation. Many of them have now Bluetooth enabled. So they have technology to transmit it. So I think artificial intelligence has entered insulinization. And also, we know with the sensors, the insulin injectors, things are getting better and better. So I personally think that I agree with you that insulin, we are in the best times to use insulin in an appropriate way, with flexibility, with ease of use, and with modern technology. Even the grip. I wish you have some pens there in the auditorium, like a quick pen or something, and you can actually show them how easy it is to use a junior or a quick pen. You know,
I
it's
think
so
we're
easy to
getting
handle.
one. We're getting one. Did we get a quick pen? Yeah, yeah. I think we're getting one.
So it's very easy to use. You can see the dial. You can see how the things are. I wish I could have been there. You know, I'm very jealous of Manoj, who has been able to go there, and I am still stuck up here. And I would have loved to be there with all of y'all in Chennai, but unfortunately, COVID prevented me from coming there. And next time, I am certain that I have promised Krishna and my friend Dr. Arvind and the whole gang of Sanjay Reddy and everybody that I'll be there. But thank you for the opportunity.
You have national responsibilities. We're grateful you're able to join us. You mentioned two things. You mentioned Dr. Manoj Chawla and concentrated insulin. So I'm going to bounce the next question about concentrated insulins to Dr. Manoj Chawla. See, Dr. Joshi has just said, we live in the era when we actually have such a plethora of devices and insulins available. Dr. Joshi has just talked to us about the variety of devices and injectable pens and things. What about concentrated insulins? We now have a range of concentrated insulins, both for basal and bolus. We are now in a Lilly symposium. What about their concentrated bolus insulin?
Right. So the idea is that we have options which will suit different needs of the patient. So right from the availability of the 0.5 unit, the junior pen, which will be extremely useful in the pediatric population, and also some patients with diabetes and CKD who are extremely sensitive to up titration of dosage, and they require that fine tuning of 0.5 units. So the pens which have 0.5 unit dosing become advantageous in these situations. In terms of the concentrated insulins, there is the U200 Humalog, which is available from Lilly's side. Now, let's understand that when we talk about concentrated insulins, up to a certain concentration, it doesn't affect the PK profile of the drug. So for U200, it doesn't affect its PK profile in terms of its PK. It is similar to U100 Humalog. But what it does is by making it more concentrated, it allows a larger amount of dose units to be available in a single pen device. So for patients whose requirement is higher, so 20 to 25 units per meal is the requirement, and they're taking that kind of dosage who are on basal bolus insulin regime. For them, with the conventional U100, the device tends to get over very, very soon. And we've had instances where the patients have come back and said that, yes, they missed a dose or two because the pen was over, they didn't find it, or even in the hospital scenarios where the requirement is higher, in some of those patients, then again, the availability, the nurse has asked for it and you're missing out on a dose. So the concentrated insulin pen allows the use to be for a longer period, kind of reduces the inconvenience for the patient who is on a higher dose to keep changing the pen device or keep looking for one or stocking extra. Even for patients who are traveling, let's understand that somebody who's on a basal bolus regime and is traveling with say Humalog and a basal insulin, they would have to carry double the amount of pens as compared to a U200 insulin, where they automatically get double the dose and their need to carry the devices becomes half. So U200 has very specific advantages. For patients who require a higher dose, it becomes advantageous. Yes, for patient who's requiring say 8 units or 10 units per meal, they may not benefit much from U200, but many others who have higher dosage will definitely benefit.
So this is flowing beautifully. I mean, you're just feeding me the lines, all of you, making my job really easy. So I was actually going to move on to the inpatient scenario for my final 2 questions. And you've just mentioned the requirements in an inpatient are different. They might be higher. They're affected by a whole lot of other factors. Dr. Rajesh Rajput, you know, and it does literally, I don't know how many of you are on Twitter and how many of you follow Med Twitter, but Med Twitter just blew up this morning because there is somebody I follow called D. Glockenflecken, and he does parodies of some of the, or skits of some of the specialties. And the endo skit he's posted today morning basically just said sliding scale insulin. And I think my heart rate and blood pressure, a pheochromocytoma wouldn't have done better in raising it. So is there still a role for sliding scale insulins? Why are we so addicted to them? Why aren't we moving on to something more physiological?
Actually, sliding scale insulin is not a physiological insulin replacement. When it comes to the insulin replacement therapy, and especially whenever we talk of sliding scale, which means patient is admitted into the hospital with some critical or non-critical illness where require meticulous control of blood glucose levels. Now, sliding scale insulin is like a roller coaster approach, where you become proactive when a nursing staff or your other hospital staff noted a glucose peak. At that point of time, you inject certain amount of regular insulin, and in between that time, patient is not on any basal insulinization, which will result in ups and downs. Now, but we are living in a scientific era. Some may argue, and because this practice still keeps on happening at number of places throughout our country, despite the teaching which we are doing over so many years. So where is the evidence? Now, there is a wonderful study which is known as Rabbit-2 study. In Rabbit-2 study, head-on comparison of basal bolus insulin therapy with sliding scale was done, where it has been proved that the degree of glucose control achieved with basal bolus insulin therapy is superior to sliding scale insulin, and the risk of hypoglycemia, which was perceived or misperceived with basal bolus, is not higher. In fact, much more hypoglycemia is seen when we become proactive by using sliding scale insulin. Having said this, you have asked what is the role. Now the terminology has changed. The concept is that in a hospitalized patient, you give basal insulin therapy, and if the sugar levels are not controlled, that is known as corrective insulin therapy or supplemental insulin therapy. So at least patient is insulinized with a basal insulin therapy. And if still there are some glycemic excursion, if patient is on oral therapy or patient is on rice tube therapy or patient is on some other type of therapy, depending on glycemic excursions, we can add supplemental or corrective doses of insulin therapy. So probably we should avoid sliding scale insulin in majority of places when we are practicing diabetes and treating patients accordingly.
So basal insulin, bolus, prandial insulin, and correction bolus.
Correction
The three
bolus insulin.
components.
Yes.
And we do all this great work, Dr. Vijay, and then it comes to discharging the patients. What's the safest way to transition them off of an intensive insulin regime that we might use in hospital onto either a basal and prandial or a premix or something that's suitable and easy and convenient for them to use at home? What's the easy? Because transition is as important as in hospital management. So how do we make that safe?
I think the first transition happens when you move the patient from the ICU setting to the ward setting. I think what we do is we calculate the 24-hour insulin requirement, which we have given by infusion pump, and you can change it to basal bolus regimen. And at discharge, we need to decide what type of regimen the patient was on before admission to the hospital, whether they were already on insulin, whether they were on oral anti-diabetic agents. And we have to make a decision whether we want to continue which type of insulin or whether they're safe to shift to oral diabetic anti-diabetics. But most often, I think for at least a couple of weeks, we'll be more comfortable in transitioning to a subcutaneous insulin regimen. I think among the regimens, what we would get easily is the premix insulin, especially the premix insulin analog twice a day, depending on what proportion they were getting in the hospital, whether you want to choose a premix 50 analog or a premix 25 analog, we need to decide. And patients should be advocated to get a glucometer if they do not have. And once they go home, everything will change. The food pattern will change. The illness changes. So it's going to be a dynamic, whatever dose you set, once they go home, their mobility, their food, everything is going to change. So we need to explain to the patient that changes will happen and they need to check the readings, and preferably they should get back the readings to us, and we need to titrate the dose. And once after a couple of weeks, we can make a decision whether we can shift over to oral anti-diabetic drugs.
Thank you very much. And the final thing is, I think, and Dr. Joshi mentioned this a little while ago, I think we're getting to the point with insulin where we're not only controlling the highs and the lows, but we have this new concept of time in range, and we're able to maintain these patients within the defined individualized range for the patient without too many glycemic excursions, either above or below. And we've had a whole lecture on time in range in the other hall about an hour ago, so I won't go in too much more detail about that. So before I conclude the session, I'd like to thank all my speakers and all my panelists. Dr. Joshi, I know how busy you are, so many thanks for joining us online and well, taking my rather googly questions. Thank you. And thank you very much, Dr. Chawla, Dr. Rajput, and Dr. Vijay. I am eternally grateful. Thank you. And I'd like to invite Dr. Gauri Shankar on board just to close the conference. Thank you.
So as we all move on to the end of the session, we would like to thank all the chairperson, speakers, audience, and pharma supports, IT people, hotel people, everybody. Would like to thank you all, and we will meet next year in 2022. Thank you all for being here. Thanks once again.